So good afternoon. My lecture has three parts: the three septic shock, and how to manage fluid resuscitation in the septic shock, and the guideline. So I'm describing within the septic shock management. I will incorporate the fluid resuscitation part. So coming to sepsis, it's a life-threatening organ dysfunction caused by unregulated host response, and septic shock is manifested by a drop in blood pressure, which decreases in the tissue perfusion, leading to tissue hypoxia, which is the characteristic of the shock. And it is still the leading cause of death worldwide. The old concept from the surveying sepsis campaign 2004, sepsis is SARS due to a document suspected or confirmed infection, with two of the following SARS criteria, like temperature more than 38, less than 36, heart rate more than 90, respiratory rate more than 20, and TLC count is less than 4,000 or more than 12,000. But now it is obsoleted. Severe sepsis also, term is obsoleted now. Septic shock is fluid resistant hypertension requiring vasopressor or lactate more than 4. And coming to screening tools like SARS, Quick SOFA, NEWS, and MUSE criteria. SARS we already discussed. QSOFA, it's done in the ward to know the high risk patient, to screen out the patient. It has three parts. Quick SOFA, systolic blood pressure less than 100, respiratory more than 20, or low GCS. If it's more than 2 or more than 2, then we can suspect patient has in sepsis. New one is like news criteria, like National Early Warning Score news. So it has respiratory parameter like respiratory rate, saturation, oxygen, systolic blood pressure, pulse, and SCPPU, like alert, confusion, command to voice, respond to voice, or pain, or to unresponsiveness, representing unresponsive, and the temperature. The score is 0 if it is it's normal parameter, and above and below that is abnormal parameter. And if it is more than, score is found to be more than equal to 3, then we should concern and tell to the nurse or senior colleague. And if it's more than 6, immediate doctor has to be consulted. The most commonly used score is the SOFA score. Actually, it's a score to know the mortality and to know the organ failure, how many organs are failed in this septic shock case. So it has 6 parameters, like in the organs like respiration, coagulation parameter, liver, cardiovascular, CNS, and renal parameter. And the score is 0 to 4. And the SOFA score is more, if it's SOFA score is more than 2, it's high likelihood of septic shock. But the more important is the change in the SOFA. If the change in SOFA is more than 2, then the mortality rate is increased to 20 times with respect to SOFA having less than 2 score. So, and it should be done the coming to the ICU and after the every 48 hours to know the mortality and know the organ failure. Now coming to etiology, most commonly by bacteria, gram-negative bacteria is the most common cause, and from that E. coli is the more commonest, and other gram-negative like Klebsiella, Enterobacter, Serratia, Pseudomonas, and in between gram-positive, staph, strepto, and pneumococcus, and virus, fungus, and parasites only in the immunocompromised cases. Source endogenous like skin, urinary tract, respiratory tract, GI. Exogenous source like surgical instrument, reps. Risk factor, the extremes of ages, malnutrited patient, anemic patient, malignancy, diabetes patient, patient having necrotic tissue, abscess, hematoma, and patient having prolonged catheterization, hospitalization, and patient having trauma and extensive wounds. Pathogenesis, that microorganisms producing the toxins and the leading to tissue damage. And these products stimulate the pro-inflammatory cytokines, which in turn stimulate the production of the secondary mediators of inflammation in order to localize the infection and limit the proliferation. So the production of the pro-inflammatory cytokines is regulated to change to limit the damage. So, but in the poorly controlled sepsis or in extensive tissue damage cases, there is excessive inflammatory responses, which is poorly regulated. So, first is the infection linked to microbial toxins. So, there is activation of the host defense. So, inflammatory responses, there is inflammatory response. If it is adequate, then there is control of infection and reducing the and the clear of the neurotoxin, clear of the toxins. And but if the inflammatory response is inadequate, so there is ongoing release of the toxin, leading to further inflammatory activation of the inflammatory response, leading to tissue injury, shock, and multi-organ failure. Coming to features, early stage, it is compensated state. So it is one shock, that is patient is not hypogenic here, patient is febrile, severing, warm, skin is maybe warm, dry, and there may be hyperventilation, rapid bounding pulse. But in the late stage, but that is in the decompensated state, that is called cold shock. There is hypovolemia, and then there is altered sensorium. Patient has been cold, clammy skin. There may be mottling in the skin. The pulse is feeble, hypothermia, oliguria, and DS may happen. Coming to investigation, before investigation, we should go in hand with the resuscitation. So first is in the CBC count, we get leukocytosis and thrombocytopenia, and we must take the blood culture from the blood, sputum, or urinary according to the source of infection. And according to suspected source, we can do the chest X-ray or abdominal X-ray or CT. Microbial cultures should be sent before the starting the antimicrobial therapy. Coming to antibiotics, the timing of antibiotics is very important. When it is sepsis is definitely more probable, then we must start the antibiotics immediately within 1 hour, though it is shock is present or not. But if sepsis is probable, then we must start immediate. If the shock is present, then we must start immediate administration of antibiotic within 1 hour. But if shock is absent, we can reassess the patient with infectious or non-infectious causes, and can be given the antibiotic within 3 hours. So patient having high risk of MRSA, so we should start empiric MRSA coverage. And if it is high risk of MDR gram negative, we should start 2 empirical coverage. And in high risk of fungal case, we should start antifungal also. But in routine case, we should not start antifungal agents. So one is source control, second is de-escalation of antibiotics. So daily assessment, reassessment is really needed. Duration of antibiotics, short or long according to the clinical scenario. But we should, if the source is controlled, then we should have a short course of the antibiotics, and biomarkers and clinical evaluation to discontinue the antibiotics. Now the second part of my lecture is resuscitation, fluid resuscitation. So how initial resuscitation is how we give fluid, colloid or crystalloid, or balance of solution or normal saline. How much should be given, either to restrictive or liberal fluid. And if it's not still not BP is not controlled, we should go for vasopressor or adding steroids. So the how we'll know there are various trials as there, like SAFE trial, 6S trial, CHEST trial, Crystal, BICEP, Alveus trial. So in a summary, SAFE trial comparing 4% albumin with normal saline, showing the equivocal result in the mortality. In 6 trial, comparing hydroxyl stars with Ringer's acetate, where there is increased mortality at day 19 and increased RRT in patients have with hydroxyl starch. In chest trial, NS with hydroxyl starch, there increase RRT in HCS case. In the crystal trial, comparing with the colloid and crystalloid, the 28-day mortality is same in the both colloid and crystal group, but the 90-day mortality day is reduced in the colloid group. In the bicep trial, there is increase in the AKI and RRT in case of patient having 10% pentastarch in comparison to the ring or lactate. And in the alveus trial, comparing 20% albumin with the crystalloid, having the equivocal result. Others like split, salt, smart trial, basics trial, and PLOS trial. All this comparing to NS and plasma lights, basically. And only smart trial favors the use of the balanced salt solution. Increase as the balanced salt solution like plasma light is better in with respect to the day mortality, RRT, and persistent renal dysfunction. So recommendations saying at least fluids at least 30 ml per kg crystalloid should be given within the first 3 hours of the resuscitation, and the further fluid based on the dynamic parameters. And crystalloid should be the first line of the fluid for resuscitation, and balanced crystalloid is the better instead of the normal saline. And patient those who require large volume of crystalloid for resuscitation, in this patient we can use albumin also. And guidelines was against the use of the starch for resuscitation. So guide for resuscitation, one is according to the decrease in the serum lactate level, and other can be in capillary refill time. Though these are the weak recommendation. For that, comparing these two, Andromeda trial has published. It has effect of resuscitation strategy targeting the peripheral perfusion versus serum lactate level on 28-day mortality. For guiding as lactate is mortality is 43, and if it is perfusion peripheral perfusion, it is 34.9. So it is equivocal result. No one is superior. Coming to restrictive and liberal, there is insufficient evidence to make any recommendation in the first 24 hours of resuscitation. But in the guidelines in the 2022 by Arabita, the trial is called classic trial. The restrictive comparing restrictive fluid group and standard fluid group, the primary outcome is 90 mortality, showing no benefit, no 42.3 death, and here is 42.1% death, no mortality benefit. So now discuss regarding some roles concept. Roles means resuscitation, optimization, stabilization, and evacuation of the fluid. So in the resuscitation space, in the statistics of there is underlying circulatory, cellular, and metabolic abnormality are associated with the greater risk of mortality than sepsis. So in these cases, we should start resuscitation. So resuscitation is a medical emergency. So we recommend resuscitation immediately, same 30 ml per kg within the first 3 hours, and further fluid according to the dynamic parameters. So initial resuscitation fluid, it's a medical emergency. So measure lactate level for first is measure lactate level and remeasure if the lactate is more than 2 after blood culture before starting antibiotics. 3 is admission broad spectrum antibiotics and begin rapid admission of fluid 30 ml per kg, and upper vasopressor if BP is less than MAP is less than 65. R then O, optimization. After resuscitation, where fluid accumulates, correlate the with organ failure. This is the phase when the fluids get accumulated in the body and organ failure starts. So must try to find when to stop the fluid. And the important factor is the indices of fluid responsiveness. And fluid administration should be stopped when the indices become negative. There's no need, then we should stop the fluid. Then the third part is the stabilization phase, where there is the absence of shock. Imminent threat is of shock is gone. So only need of maintenance fluid. So daily needs of water, glucose, and electrolytes should be achieved in the nutrition. So we should not give more. We should not give the IV fluids. So we know the various. If you give more fluid, there is a problem with the fluid overload in the various organs. Like the respiratory, there is pulmonary edema, increased pleural effusion. There is extravascular lung water, increased extravascular lung water. In hepatic, there is congestion, impaired synthetic function in the GI. There is increased ascites, gut edema, malabsorption, decreased gut motility, and the abdominal decrease in the tissue edema. There is poor wound healing, decreased abdominal complaints, and the CNS get cerebral edema, increased ICP. In cardiovascular, there is myocardial edema, poor myocardial contractility, or increase in CBP. And the renal also, there is an increased interstitial edema leading to decreased renal blood flow and increased uremia. And the last is the evacuation phase. So where we start aggressive and fluid removal using diuretics or through RRT. And other strategies like should moderate fluid strategies should be followed after the initial resuscitation. Here is the phase where we to start the fluid removal. So balance between the benefits and of fluid reduction and the risk of fluid removal must be there, or else hypoperfusion may be occur. So testing of preload responsiveness still useful here. So if the preload responsiveness is still there, so we should restrict the fluid removal. So here is the two graphs. Like in the first phase, cumulative fluid balance and the time, exactly there is time. If we give the fluid fast in the resuscitation phase, the fluid starts accumulating. Then it is in the minutes. Then after in the hours, it is still increased over the hours. Then if we still give the fluid in the stabilization phase also, in the days also patients start accumulating the fluid. But after that, we should evacuate the fluid, and over the weeks it start cumulative fluid become negative. Similarly, it's the organ failure and with time graph. So fast in the sepsis, in the septic shock, fast the organ failure risk is very high. So we should give the fluid. Slowly, the organ failure risk is decreased. And again, there is the chance of organ failure risk has been increased with the if we give more fluid. So, but after the evacuation phase, if we restrict the fluid, then organ failure risk also start decreasing. So next, the fluid resuscitation is completed. Now coming to that septic shock management. If it's not controlled, BP is not controlled with the fluids, then we go for the vasopressor. So recommendation shows that norepinephrine is the first line of agent, and it's a strong recommendation. And if it's treated, we should add the vasopressin rather increasing the norepinephrine dose. And still it's not controlled, then we should go for the epinephrine. And still BP is not controlling, then we should go for adding steroids. For steroids, adding steroids, there is corticosteroid, acrosteroid, and renal. Corticosteroid says that 50 mg of hydrocortisone 6 hourly, This leads to faster resolution of shock, but there is no mortality benefit. In approach trial, with hydrocortisone, we should add fluorocortisone 50 microgram OD. There is mortality benefit in the 90-day. And the adrenal trial shows 200 mg of infusion. There is also no mortality benefit. So, septic shock patient ongoing requirement of vasopressor, we should suggest the IV corticosteroid 200 mg per day as an infusion or 50 mg 6 hourly. Only if it is norepinephrine dose is more than 2.25 max per kg per minute, at least for 4 hours. Coming to vitamin C, Lobit trial suggests against the use of vitamin C. Coming to blood purification, recommendation suggests against the use of any blood purification like polymation, VIM, or other blood purification techniques. Coming to thromboprophylactis, we must use pharmacological thromboprophylactin like low molecular heparin and recommendation against any mechanical thromboprophylactis. In addition to the pharmacological, as the trial from the orbital, the all patients receiving LMWH, but the intermediate group, control group is the no pneumatic compression, and the other is having compression, pneumatic compression. So the new thrombosis incidence is the same. So no significant difference in the incidence of DBT. So we should not use the intermediate compression devices along with the LMWH. So third part of the lecture is recommended the guidelines in the 2021. So describing only the strong recommendation, as there is more than 90 recommendations are there. So describing only the strong recommendation. So for hospitals and health systems, we recommend using a performance improvement program for sepsis, including sepsis screening and for acutely ill and high risk patient, and standard operating procedures must be there in the hospital for the treatment. And we recommend against the use of any use of over the SARS news or news score for patients having septic shock on vasopressor. The initial treatment, initial target is map of 65, not the higher map. And for patients, the antibiotics should be administered within the 1 hour of recognition. And the fluid choice is crystalloid. We recommend against the use of the starch. Now referring to the first line of vasopressor. And if there is a patient having ARDS, the goal is to limit the blood pressure less than 30. And recommended suggesting restrictive strategy is better than the liberal strategy. And DBT only by pharmacological method. And insulin therapy should be given only when the glucose level is more than 180 milligram per deciliter. And vitamin C should not be used. Thank you.
Thank you, Biswajit sir, for that lecture. So without wasting time, let's move to the next presentation. That is resistant gram-negative and a gram-positive bacterial infection. To take the lecture, I would like to invite Dr. Rupali Patnaik, ma'am, Associate Professor in the Department of Critical Care Medicine. Ma'am, please share your slide and proceed the lecture.
You answered the previous one, no? Answer this one, no? Cherian.
Yes, ma'am.
You answered with Dr. Biswajit's slides.
Biswajit sir, can you just mute your slides? Ma'am, you can share your slide now.
Yeah. Yeah, is it visible? Should I
Yes,
start?
yes.
Today I'll be dealing with the resistant gram-negative and gram-positive organism. Basically, this is need of the hour because antimicrobial resistance, it is very much threatened these days. Like it is the antimicrobial resistance, the increased incidence of mortality due to antimicrobial resistance. Like in, it is thought that like in 2050, almost 10 million people will die in 1 year because of the antimicrobial resistance. So there is high need for newer antimicrobials because of development of resistance in the gram-negative and gram-positive organisms. So 1 person every 3 seconds is dying by 2050. This is if we are not tackling this antimicrobial resistance at present. Coming to timeline of antibiotic resistance, the first antibiotic came is penicillin. It is in 1939. From this, when Fleming discovered antibiotic penicillin, that time only he told that there is high chance of antibiotic resistance to penicillin is soon after developed. So the antibiotic resistance have observed with the penicillin resistance soon after the development of this penicillin. That is, antibiotic resistance is going in hand with the development of newer antibiotics. And the most important point is the antibiotics. That is there is after 2005, there is very less antibiotics are being discovered. The initial times there was higher number of antibiotics were discovered, but there is a lack of antibiotic void. By after 2005 or 2007, there is very less number of antibiotics are being discovered. So the antibiotic pipeline is basically empty. This is the need of the hour to think for this antibiotic resistance and proper use of antibiotics. Is before we'll discuss first with the gram-negative bacteria, and then we'll go to gram-positive one. What is the difference in gram-negative and gram-positive bacteria? And gram-negative bacteria, it is different from the gram-positive. Is like it is an outer membrane. Outer membrane is important in gram-negative bacteria, followed by one thin layer of peptidoglycan, then periplasmic space and cytoplasmic membrane. In gram-positive, this peptidoglycan layer is the more important and the predominant structure. It doesn't have a outer membrane is like the gram-negative bacteria. And various resistant the mechanisms where the antibiotics work. The cellular synthetic inhibitors are the beta-lactam antibiotics, penicillin, cephalosporin, carbapenems, and monobactams like Astronium. And vancomycin and cell membrane synthetic inhibitors are polymyxins. Then comes the nucleic acid synthesis inhibitors. These are the nucleic acid synthesis inhibitors like folate synthesis inhibitors are sulfonamides or trimethoprim that we use the cotrimoxazole. No, here are the folate synthetic inhibitor. Then the other nucleic acid synthesis inhibitor like DNA gyrase inhibitor are the quinolones and RNA polymerase inhibitor rifampicin. Then comes the ribosome. Now, 30S ribosomal subunit inhibitors are mainly tetracyclines and aminoglycosides, most important. And 50S ribosomal subunits are the inhibitors are the macrolides, clindamycin, linezolid, chloramphenicol, and streptogramins. Then mainly resistant gram-negative organisms. I'll mainly focus on the carbapenem resistant organisms, which are most important these days. So carbapenem resistant is gram-negative bacteria is worldwide problem. In 2017, WHO global priority list of these pathogens like CRE, carbapenem resistant enterobacteriaceae, CRPA, carbapenem resistant pseudomonas aeruginosa, and carbapenem resistant Acinetobacter crab. Acinetobacter problem. These are the main global threat has been declared with these pathogens. Then what is the mechanism of carbapenem resistance? The key mechanism is the hydrolysis of carbapenems by the carbapenemase enzyme. This is the enzyme. It's like it's a beta-lactam, one of the beta-lactamase enzyme which hydrolysis the carbapenem back in this carbapenem antibiotic. This encoded mainly on plasmids and highly transmissible. Carbapenemase enzymes are mainly encoded by plasmids, so they are highly transmissible. The Umbler classification, they are categorized these beta-lactamase enzyme into 4 groups, A, B, C, D, based on their catalytic domain and substrate difference. So class A, B, D are the carbapenemases, and class C mainly it hydrolyzed cephalosporins. enzymes why they are A, C, and D. They are serine carbaphenemases because of their active catalytic site contains serine group. And while class B, the metallo-beta-lactamase, it is active site zinc, so it is called metallo-beta-lactamases. This is the amlar classification. Carbaphenemases or beta-lactamases. They are divided into either serine beta-lactamases having serine catalytic group and metallo-beta-lactamases having zinc as the catalytic group. It is like A, C, and D. These three groups are the serine beta-lactamases. Class A is having KPC, like Klebsiella pneumoniae, carbaphenemases producing. IMI is imipenemase, imipenem hydrolyzing beta-lactamase, and SME. These are the main one, like Serratia, Serratia marcens enzymes. This is main class A. Class A are serine beta-lactamases. Then class C is the ARM-C beta-lactamase. ARM-C and others are the class C beta-lactamase. Then most important are class D. Class D are the OXA variant, like OXA 48, OXA 23. They are most important clinically for the culprits. Then metallo-beta-lactamases are class B. It mainly includes three, like NDM, VIM, and IMP. NDN is New Delhi metallo-beta-lactamases. IMP is imipenemase metallo-beta-lactamase. VIM is Verona integrase metallo-beta-lactamase. Then apart from the carbaphenemases, these hydrolyzing enzymes, there are some other mechanisms of carbapheneme resistance. The most common is hydrolyzing enzyme carbaphenемase production is like told in amlar classification. Others are like loss of expression of porine encoding genes. What are porins? Basically, porins are like they are present in the outer membrane of these gram-negative bacteria. These porins are helpful for basically their nutrient channels. These channels are active channels through which nutrition and various nutritional substances and even antibiotics they enter to the bacterial cell wall. So there can be loss of expression of this porine encoding genes, mutation in the chromosomally encoded porine genes, and overexpression of genes including efflux pumps. Either there is loss of expression of the porine or there is altered porine channels, or there can be overexpression of the efflux pumps. This overexpression of efflux pumps mainly important in infection with Pseudomonas aeruginosa. Here is this is the flowchart. Gram-negative origin CRE, carbapheneme-resistant enterobacteriaceae. This is CP is carbaphenемase enzyme producers are KPC, OXA, and NDM, VIM, IMP. Non-CP mechanisms are like carbaphenемase producing mechanism, porine and influx pump. Then for non-fermenters like Serratia also, the CPO and non-CPO, they are carbaphenемase producing organism, CPO. It is like KPC and OXA, or like this metallo-beta-lactamases like NDM, VIM, and IMP, or non-CPO mechanisms are like porine and influx pump mainly. Then what we have to tackle these resistant organisms, that is, what are the newer antibiotic classes we have. This can be newer BL-BLI combination, beta-lactamase and beta-lactamase inhibitors to tackle this, like ceftazidime avibactam, ceftolozane tazobactam, meropenem carbapenem, imipenem cilastatin delibactam, or aztreonam avibactam combination only. In tetracyclines, avarcycline, omadacyclines, and aminoglycosides like isopamycin, plazomicin. And Tedijolid is the oxazolidine, and siderophore antibiotic is cefiderocol. These are the newer antibiotics which are proposed. Basically, out of these, we don't have much more with our hand. We have only at present ceftazidime avibactam and aztreonam with us out of these newer BL-BLI combinations. Then coming to these newer antibiotics, these are main FDA status, all are FDA approved. Coming to ceftazidime avibactam, it is like 2015 FDA approved, mainly to activity against KPC and OXA 48, ceftazidime avibactam. First started by Javisepta by Pfizer, but now various brands are available. Coming to what is the benefit of adding the avibactam here? With this, I'll start with the class of beta-lactamases. The beta-lactamase inhibitors are basically first generation and second generation. The first generation ones like clavulanate, tazobactam, and sulbactam, they are helpful like in covering TAME, SSBs, these phenotypes, but they are not at all active for KPC, OXA, MBL, and all that. Then this avibactam, it is the second generation beta lactamase inhibitor, which is compared to the first generation. The second generation, this is avibactam is advantage. It doesn't have a beta lactam ring. Others, the other beta lactamase, the previous ones have a beta lactam ring, which are being hydrolyzed by the beta lactamases. But this avibactam, they do not, this it doesn't produce the beta lactam ring, and not, that's why difficult to hydrolysis. And it is active, it's like it effective against all the see, it is like SSP variant or CTX, KPC, and OXA also. But it is not effective for the MBL or new, that is like metalobictam, is nothing effective. That's why we are adding H2NM with the combination. See, this is like the avibactam. The spectrum activities, it covers both class A, class C, and class D, but not class B. Helpful for complicated urinary tract infection, intra-abdominal infection, hospital-acquired pneumonia, and ventilator-associated pneumonia, and various pathogens are like Enterobacter, C. coli, Klebsiella, Citrobacter, Proteus, Serratia, Pseudomonas. All are effective with this Septaginium avibactam and with Septaginium avibactam combination. This is the CLSI and TUCAST, the cutoff level, 8 milligram per liter is the both. Then comes the other antibiotic, ceftolozane tazobactam. It is a cephalosporin, structurally similar to ceftazidime only, thiazidine cephalosporin. Specificity, it mainly more of activity towards Pseudomonas, like most of the studies. So it is ceftolozane is more activity compared to other antibiotics, like more to Pseudomonas. Tazobactam is like activity on ESBL of class A, but it is not on KPC or MBLs. Similarly, complicated UTI, intra-abdominal infection, hospital-acquired infection, and the various bacteria which are susceptible, is like the previous septum. This is the UCAST and CLSI, -4 milligram per liter is their cutoff level. Doses like here 2 gram, 8 hourly is the mainly for complicated ventilator or hospital-acquired infections. Coming to this, it is effective for class A, but not to class B, and even not for class B. So, and OXA also. We have avibactam is better, ceftazidime avibactam combination is better than this. Options are for ESBL producer, best option for Pseudomonas mainly, and not option for carbapenemase producer like KPC and MBL. It is obviously not effective. Okay. Then other is like meropenem bhavarbactam. It is a newer BLBLA combination. New generation beta lactamase inhibitor is the bhavarbactam with specific activity more to KPCs. Compared to meropenem, no additional activity on Pseudomonas and Acinetobacter or Stenotrophomonas. Complicated UTI and hospital-acquired and ventilator-associated pneumonia. These are mainly reserved for cases resistant to other carbapenems. But activity, obviously, like the here, this also covers meropenem bhavarbactam combination, all except the beta lactamase oxalate also. The UCAST and CLSI recommended -8 milligram per liter. Best options for KPCs, obviously, and not options for MBL and OXA 48. Then imipenem cilastasen relivectam, it is recently approved. Obviously, it's not available in India. We don't have many of these newer antibiotics with us. And dose is like 1.25 gram every 6 hourly. Complicated and intra-abdominal infection, it is FDA approved. All susceptible bacteria and enterobacterias, and even anaerobes also. Spectrum is like effective like in others, like not in class B or OXA. Similar to meropenem bhavarbactam for KPC and enterobacterias, but not option for MBL and OXA 48. And better Pseudomonas and Acinetobacter cover compared to others. So, like ESBL, ceftazidime avibactam, and it is covers the ESBL, the CTX, but not option for metallo-beta lactamases. Also, it covers OXA48, but it doesn't cover only the metallo-beta-lactamases. So we have only this one available with us. And astronom 8 here to cover this metallo-beta-lactamase activity, which is not there with the ceftazidime and avibactam. Then coming to aminoglycoside, plazomycin is a recently approved aminoglycoside. Dose is 50 milligram per kg, and obviously there is dose adjustment as per the creatinine clearance level. Complicated UTI, it is FDA approved. The susceptible bacteria are Enterobacteriaceae production, and additional MRS and polymyxin resistant cover also proposed. Plazomycin, it is covers all these. It is a proposed one, but obviously we don't have this antibiotic with us. This is the aminoglycoside recently approved. Options for MBL except New Delhi metallo-beta-lactamase producing 16S methyltransferase, better Pseudomonas cover. Fungible polymyxin resistant cover also with proposed with this newer antibiotic. Then comes the iravacycline. It's a synthetic fluorocycline similar to tigecycline. Usual dose is 1 milligram BD and administered about 1 hour infusion. Main issues with the liver disorder where this dose has been adjusted. UCAST has suggested minus 0.5 milligram per liter is the cutoff level. It is approved for complicated intra-abdominal infection and susceptible bacteria are Enterobacteriaceae and with MBL production, additional MRS and Acinetobacter combination. Iravacycline, it is effective in like not more of like Pseudomonas or AMC coverage, but it covers others, class A, B, and D. And this is the UCAST options. The options for MBL Enterobacteriaceae, no role for Pseudomonas, and Acinetobacter Stenotocomonas coverage. Then astronom and avibactam combination, it can be helpful. Obviously, as I told, it is the astronom which covers the class B metallo-beta-lactamases, which is effective in combination with the avibactam. It's a zone of 4 for MBL and OXA48. 2.5 gram entirely dose we use. The cefiderocol, it is a siderophore cephalosporin, dose is 2 gram entirely. The inhibition of hydrolysis of beta-lactamases mainly mechanism is the Trojan horse strategy. It is effective, basically proposed for all of the class A, B, C, and D. But this is also not available with us. It is a hope for MBL and OXA48, which are mainly resistant bacteria available, and options for Acinetobacter Pseudomonas, Stenotocomonas, and Burkholderia also. Then coming to gram positive bacteria. Gram positive bacteria, main gram positive bacteria, Staphylococci, Streptococci, and Enterococci. Coming to Staphylococci, and its resistance to antibiotics. The beta-lactam and Staphylococci. The emergence of dissemination of beta-lactam resistant in staph aureus happened in several epidemic waves. The first wave is plasmid encoded penicillin. It was started in 1950. The second wave, by 1959, after introduction of methicillin, there was emergence of hospital-associated methicillin MRSA isolates that primarily circulated in the European hospitals. Third wave is development of spread of several highly successful hospital-associated MRSA clones. And followed by 1990, there is emergence and dissemination of community-associated MRSA also. So currently, most staph aureus are mainly penicillin resistant, though the production of plasmid-borne beta-lactamases, there are 4 types are known, A, C, and D. Methicillin resistant is based on acquisition of staph chromosomal cassette. It's a SCC MAC gene that contains MAC, a gene which encodes penicillin binding protein 2A, a transpeptidase, which is low affinity for all beta-lactamases. This is the main reason for methicillin resistance. This is altered penicillin binding protein due to chromosomally mediated MAC, that is SCC MAC gene. Newer addition to beta-lactam family like these antibiotics, ceftaroline and ceftobiprole, has potent activity against MRSA due to their enhanced activity for this penicillin binding protein 2A. There are the newer antibiotics which are proposed for these methicillin resistant organisms. Then comes the glycopeptide and staph. Staphylococcus reduced vancomycin susceptibility. These are classified into two phenotypes. Vancomycin intermediate sensitive Staph aureus visa with MIC of 4 to 8 per ml and vancomycin resistant Staph aureus VRSA when MIC is more than 16. Fast reported visa isolate from a vancomycin susceptible strain. Then what is heterogeneous visa or heterovisa? This is which have later found a subpopulation with MIC even more than 2. It is heterogeneous visa. These intermediate sensitive or heterogeneous typically they develop in vivo patients. Patients are with invasive staphylococcus infection and they are receiving prolonged vancomycin therapies. These patients develop this type of isolates, and it is isolated from these patients who got prolonged vancomycin therapy with disseminated staphylococcus infection. Despite low overall prevalence, these intermediate sensitive and heterogeneous Staph aureus can reach up to 30% selected clinical features, such as patients with MRSA and infective endocarditis. Genetic basis of this is complex, involving multiple sequential mutations that typically involve several regulatory systems controlling cell envelope homeostasis. And various genes are implicated in this. These genetic changes cause significant remodeling of the cell envelope, creating thickened cell wall and increased amount of these dipeptides, so that there is a reduced cross-linking of this, because these are mainly cellular synthetic inhibitor. So this reduced cross-linking occurs, and this lead to resistant of this organ. These organisms are not working. Then VRS was vancomycin resistant Staph aureus. Started in 2002. This resistant came due to acquisition of Van A gene cluster from vancomycin resistant Enterococcus faecalis. 3 antibiotics from the glycopeptide family like telavancin, dalbavancin, ortivancin. These are the newer ones which have been proposed by the US FDA for the treatment of gram-positive infection. They are active in vitro against these isolates, basically. These isolates, these are the newer antibiotics which are proposed to be active for the intermediate sensitive Staph aureus. Then comes oxazolidins and staph, like linezolid. These resistance arise due to mutation in genes encoding ribosomal protein. As I told, these work there in 30S ribosomal subunit and alternates in the ribosomal protein methylation of the 23S RNA by methylase, one of the methylase enzyme. This is responsible for this. Most common determinant of linezolid resistant is the central loop of the domain of the 23S rRNA. This is here is the linezolid works. This 23S rRNA section. This is responsible for the linezolid resistance events for the gram-positive organisms, for the Staphylococcus aureus mainly, which is culprit for resistant. The CFTR gene, this is associated with various mobile genetic elements and co-transmits with other resistant determinants. It is high potential for MDR trait dissemination. This CFR gene is the main culprit for linezolid resistant in the Staph aureus. The CFR mediated linezolid resistant may overcome higher antibiotic doses, and this does not come for resistant to tedizolid. Tedizolid is a newer antibiotic for the linezolid receptor, and this gene doesn't act for it. It's usually effective. Then comes to resistant for the daptomycin. How daptomycin works? The unstructured peptides in this solution, they interact with the peptide, with the membrane peptides, and the integration of the peptide and thinning of the outer leaflet. This leads to thinning, then formation of the pore. There is membrane, this formation of pore leads to membrane depolarization, micellization, and internalization of peptides that lead to cell death. The mechanism for the daptomycin, which works. Then for the daptomycin resistance has been encountered in the staff. The daptomycin resistance during therapy has been important issue. Mainly during daptomycin therapy, these patients develop resistance. The exact mechanism still difficult to understand. Most staff remain susceptible to dapto, but there are some increasing reports of emergence to it, especially in high local node infection and after exposure to vancomycin. Proposed mechanism of this is mediated by electrostatic repulsion of daptomycin calcium complex from the cell surface. Okay. This is achieved mainly by increasing the positive charge on the bacterial surface that leads to repulsion of the daptomycin calcium complex, so that the membrane thinning and the followed by the efflux is not being possible. This MPRF gene is one of the frequently implicated in the resistance phenotype. Then comes the enterococcus and beta-lactams. The MIs of penicillin and ampicillin, most active anti-enterococcal beta-lactam, much higher enterococci than other common gram-positive organisms. This is likely due to expression of low-affinity penicillin binding protein, mainly penicillin binding protein 5. This is responsible for the enterococcus resistance. These enterococcal isolates often tolerant to beta-lactam antibiotics, means that these drugs lack bactericidal activity in vitro. This complicates treatment of serious infection. High levels of resistance to ampicillin is characteristic of basically that we get the MDR enterococcus physium isolates. This high level of resistance for this high level of mechanism fully understood, but they are often linked to these changes in the penicillin binding protein 5, which is now for low affinity for the beta-lactams. Then vancomycin and enterococcus. Vancomycin resistant enterococcus most prevalent in enterococcus physium isolate. They are mainly vancomycin resistant, VR resistance. With spread of enterococcus physium traced to the dissemination of hospital-associated gentecula that often exhibit multi-drug resistance, including other antibiotics, including ampicillin, to high-level aminoglycosides also. These VRE isolates from acquisition of VAN gene clusters, likely from environmental organisms. The most common gene clusters is VAN A, typically located on transposon mediated, found in conjugative and non-conjugative plasmids. So this is VAN A gene is mainly responsible for the vancomycin resistant enterococci. Then some treatment options available. Obviously, we have vancomycin, linezolid, and cephalosporins with that, and daptomycin, and but others like newer proposed therapies against gram-positive organisms are ceftaroline, ceftobiprole, dalbavancin, ortivancin, and tedizolid. These are tedizolid is mainly effective for MRSA, cons, and enterococcus physium, including VRA isolates also. And clinical studies is also tedizolid is found to be better than linezolid for VRA isolates also. Not going into detail each of these antibiotics. Okay. Thank you.
Thank you, Rupali ma'am. So with that, we will move to our next lecture. That I invited Dr. Sanjeev Dar sir to please share your slide. We have the topic of neutropenic sepsis in ICU. Sir, over to you, please.
Is it visible now? Children?
Yes, sir.
Is it visible?
Yes, sir. Yes, sir.
Okay. So good afternoon. The next topic is neutropenic sepsis. The previous topic is passed and presented by Dr. Pali very nicely. And this topic is neutropenic sepsis. How we count neutropenia in a patient? So the absolute neutrophil count can be calculated by multiplying your percentage of polymolecular cells with the total white cell count, and the not only the polymolecular cells, also the bands with the total white cell count. So you get the absolute neutrophil count. So how we define the neutropenia? With that, absolute neutropenia is defined when the absolute neutrophil count is less than 1500 per microliter, and severe neutropenia when ANC is less than 500, and the profound neutropenia when absolute neutrophil count is less than 100, and the protracted neutropenia when the neutropenia is persisted for more than 7 days. And as far as neutropenia is concerned, our target should be ANC should be maintained more than 500, and if a patient having ANC less than 500, we should treat it properly so that patient have an absolute neutropenia more than 500. So febrile neutropenia patient, how we define febrile neutropenia? So a single temperature of more than 38.3 degrees centigrade or more than 101 Fahrenheit, or a temperature of more than 38 degrees centigrade that is persisted for more than 1 hour. So these two, either of the two criteria should be there to define as a febrile neutropenia. So some more definitions are there. So what is fast neutropenic fever? So this is a fast febrile episode during a given period of chemotherapy induced neutropenia. And what is persistent neutropenic fever? When the febrile episodes without defermentation after at least 5 days of initial broad spectrum antibiotic therapy in high risk neutropenic patient, or that persist for at least 2 days in low risk neutropenic patients. So in high risk patients, if despite antibiotic that fever persists or don't differ, so for at least 5 days on, or in low risk patient if that persists for more than 2 days. What is again recrudescent neutropenic fever syndrome? If the febrile episode that recur following the initial deformations during a course of broad spectrum antibiotic given to the patient. So some other terminology, neutropenic fever syndrome. So the International Immunocompromised Society classified neutropenic fever syndrome into 3 categories: the microbiologically documented infection, or clinically documented infection, or unexplained fever. In microbiologically documented infection, there should be neutropenic fever and a clinical focus of infection and associated pathogen and pathogen prevalent. But in clinical documented infection, all this should be present, but there is no documented or associated pathogen. So neutropenic fever should be there, a clinical focus should be there, but without associated isolation of associated pathogen. And in unexplained fever, neutropenic fever should be there, but without any clinical focus or proven kind of pathogen. So epidemiology, for epidemiology, an infectious source is identified in about only 20 to 30% of febrile neutropenic episodes. But often the only evidence for infection in neutropenic cases is the bacteremia that found in only 10 to 25% of the all neutropenic patients. And approximately 80% of the identified infections are believed to be arising from the patient's own endogenous flora. That is, in patients, neutropenic patient that may be translocated from the gut or any breach in the normal barrier. So what are the common isolates from the blood of the febrile neutropenic patient in Indian setup? So most common are the gram-negative, followed by gram-positive, or there may be can be polymicrobial. So common pathogens are in bacteria. The gram-positive are the coagulation-negative staph aureus, or staph methicillin-resistant staph aureus, or Streptococcus pneumoniae, Streptopyogen, or Enterococcus, including the Vanco-resistant Enterococcus, or Viridian group Streptococci, or Burkholderia. In gram-positive, all the Enterobacteriaceae family can occur: E. coli, Pseudomonas, Klebsiella, Enterobacter, Acinetobacter, Cytobacter, and Pseudomonas. Similarly, fungi, the Candida, Aspergillus, Gycomatis, and Pneumocystis, and Cryptococcus. These are the more common. As far as virus is concerned, varicella zoster, Warthitis simplex, and cytomegalovirus, and other respiratory virus like respiratory syncytial virus, influenza, parainfluenza are common. And sometimes malaria parasite can occur also. And so contributing factor to the pathogenesis, there can occur the direct effect of the chemotherapy on the mucosal barrier and the immune system, and there is breach in the host defense related to the underlying malignancy. So either or both of these can lead to pathogenesis. So how I assess a patient having neutropenia or neutropenic sepsis? So we have a score. This is known as a mask score. This is multinational association of supportive care in cancer risk index that is created to assess the risk of a serious complication in neutropenic patients. So the mask score total score is 26. If score higher the score, better the prognosis, and less is the score, the worse is the prognosis. So this will go through. This is the mask score. The component parameters: age less than 60, onset of fever while patient outpatient, or or outpatient heart service patient, or a moderate symptom burden, or a patient having or absence of dehydration, no prior fungal infection or solid tumor type, or no history of COPD, or absence of hypertension, or asymptomatic or overall mild symptom burden. So if we'll add all these, there are the points. If the score is more than 12, this is a low risk, and if the score is less than score is more than 21, that is the low risk. If risk is high, that is less than 21. So again, why risk assessment? By clinical criteria based, if high risk, if absolute neutrophil count is less than 100 microgram per liter, or predicted to be less or more than 7 days. And if a patient is hemodynamic instability, or there is or gastrointestinal mucositis with dysphagia or severe diarrhea, or GI symptoms like nausea, vomiting, or new onset neurological changes, or alternate mental status, or intravascular catheter-related infection, or new onset lung infiltration, or new hypoxemia, or any chronic lung diseases, or hepatic failure having transaminases that ranges more than 5 times from the normal value, or renal failure is there. So and masks are also less than 21. And low risk patient, these are neutropenia expected to be resolved within 7 days, and there is no active medical comorbidities or stable hepatic or renal function. So we assess the risk by either mass score or by clinical criteria. So how we go about the neutropenic patient? The laboratory test, we initially send the blood culture along with the basic routine examination like complete blood count, here creatine, body nitrogen, LFT, electrolyte, X-ray, all this. So we should send at least 2 set of blood culture before starting the antibiotic. One from the manufacturer site, another from catheter, central venous catheter, and 2 set. And each set should have 20 ml blood. That is 10 ml in aerobic and 10 ml anaerobic blood bottle. I mean culture bottle. If body weight again is less than 40 kg, then total blood volume should be taken should be less than 1%, and total body weight is total blood volume counted by 70 ml per kg body weight. Other we can take the stool culture in patient having the diarrhea or difference. We can test for the antigen for the toxin for the Clostridium difficile. And similarly, urine culture we should take in patient having UTI, urine catheter-related infection, or having urine, or patient having abnormal urine analysis, or having high pus cells. CSF analysis if patient presented with meningitis. Similarly, skin aspiration of biopsy if there is skin site infection, or we should can send also Granster or other culture. Similarly, respiratory specimen, we can, if person have product cough, if there is a lung will filtered on chest X-ray in outbreak season, we should take for TT secretion that Granster culture, and bulk specimen we can take for nasal swab, or bulk specimen for adenovirus, influenza virus, or respiratory syncytial virus if there is outbreak season. We should take it on chest X-ray. And CT scan we can do if you don't find any other definitive sign we don't find, then we can go with the CT scan of the head, sinus, paranasal sinuses, abdomen, or pelvis. So how to approach the neutropenic patient? So before that, some terminology are there. So what is primary prophylaxis? When administration of antibiotic given to patient to prevent the infection in patient at increased risk. What is secondary prophylaxis? So these are administration of antimicrobial drugs to prevent the recurrent of infection. So first from the primary prophylaxis, before the infection ensues, we start the antibiotic. But secondary prophylaxis is the antimicrobial that to prevent a recurrent of the infection. What is empiric antibiotic? This is the symptom-based starting of the antibiotic. But if preemptive antibiotic, we give antibiotic based on the serology or antigen testing. So empiric antibiotic, this is in patient with chemotherapy-induced neutropenia. Initiation of the therapy at the time of onset of a neutropenic fever, but before the firm diagnosis of bacterial movement or any antigen or any microbiological assay. So this is a standard part of management in neutropenic fever. So preemptive therapy, this is initiates of therapy based on screening with a sensitive microbiological assay like antigen detection or microbiological assay. That is, we do that beta-2-glucan or galactomannan in fungal infection to see the fungal infection, and it is to avoid. This is not to avoid the progression to the invasive disease and start by starting a proper antibiotic. antifungal. So this is the guideline 2010 IDSA guideline. The empiric antibiotic that should be started within 60 minutes of the recognition infection after taking the blood culture sample. So in high risk patient, manage as inpatient, but low risk patient can be managed as an outpatient. But sometimes this can manage this will manage as inpatient depending on the patient's condition. So empirical therapy in a high risk patient, along with the broad spectrum antibiotics should contain one anti-pseudomonal antibiotic. These are the cefepime, pipocresol, tazobactam, or carbapenem. Vancomycin should be added if the patient is hemodynamically unstable or there is catheter-related burst infection, skin septic infection. And if patient again having MRSA and vancomycin, linezolid, or daptomycin should be added. If vancomycin entrecocci, linezolid, daptomycin should be added. And the patient is having ESPL, then carbapenem should be added. Klebsiella carbapenem again we should add the polyp or colistin or tigecycline. And if the patient having a penicillin allergy, then we can go with the astrona and vancomycin. Ciprofloxacin can be given to the patient. So in low risk patient, this patient should be managed outpatient or inpatient depending on the patient condition. So initially we give orally. If required, we can go with IV formulation. So empirically with aminoxidil carbonate and ciprofloxacin, or we can give ciprofloxacin with the clindamycin, or a fluoroquinolone monotherapy can be given also in low risk patients. So if low risk patient, the hospitalization required if fever persists or infection worsens, or there is predictive factors like the age more than 70 years, or grade of mucositis is more than 2, poor performance status, or absolute neutrophil count less than 100 at the outset of the fever. So in this patient, in low risk patient, we should manage as an inpatient. So the IDC guidelines tells us there is no role of empirical antifungal therapy. So, but before giving antifungal therapy, the investigation for the antifungal infection in favor for more than 4 to 7 days on antibiotic or neutropenia expected to persist for more than 7 days. So initially, if the patient is already on antibiotic and that fever does not subside, then we should go with we should send for the fungal infection called. We should send investigation to detect the fungal infection, and if the patient having neutropenia suspected to have persistent neutropenia for more than 7 days, within this patient we can start the antifungal. If the patient is already on antifungal, then switch to a different class of antifungal because the patient having already antifungal and a patient again having a fever, then switch to a different class of antifungal or change to an IV antifungal formulation. Pre-antifungal in high-risk patient who are febrile yet clinically stable with the evidence of a possible fungal infection. So antifungal prophylaxis given if the candida species is suspected, then candida prophylaxis should be given in allogenic hematopoietic stem cell transplantation recipient or patient having intensive treatment of acute leukemia. So in this patient, fluconazole and azole should be given, like fluconazole, itraconazole, voriconazole, posaconazole can be given, or patient is having on hematite unstable and chronic candida battle and becoming casoconazole. And in aspergillus, again, in patient above more than 30 years undergoing intensive chemotherapy treatment for acute leukemia or myelodysplastic syndrome, the antifungal against aspergillus should be given. Patient with fever, prior history of infectious aspergillosis before starting the hematopoietic transplantation, or anticipated neutropenia that can persist for more than 2 years. Within cases, infectious aspergillosis prophylaxis should be given with the posaconazole. That antifungal prophylaxis again is in low patient is not recommended if the anticipated period of neutropenia is less than 7 days. So these are some of the empirical therapy. What is how go about the prophylaxis? The recommendation for prevention of infection in neutropenic patient. So fluoroquinolone prophylaxis given in high risk with high risk patient with expected prolonged or profound neutropenia that absolute neutropenic count less than 100 that can persist for more than 7 days. So in proper neutropenia that can persist for more than 7 days, we can give fluoroquinolone prophylaxis. In low risk patient, there is no recommended. It is not recommended if expected reduction of neutropenia is less than 7 days. Again, antifungal with an oral triazole in patients with profound neutropenia should be given as a prophylaxis, and trimethoprim sulfamethoxazole for patient chemotherapy regimen with associated risk of pneumonia for pneumocystis cerevisiae pneumonia. And antiviral prophylaxis with acyclovir valcyclovir for all patients who are seropositive for herpes simplex virus undergoing allogenic hematopoietic stem cell transplantation or induction chemotherapy for the acute leukemia should be given. And the National Comprehensive Cancer Network guideline that recommended that the granulocytic colonist immunity factor, the filgrastim for high risk patient to increase the neutrophil count. And EUD influenza vaccination is recommended for all patients that are receiving the chemotherapy. This is again the same agreed by the IDSA guideline. And in patient with influenza outbreak, neutropenic patient with flu-like illness should be treated with empirical with neuraminidase inhibitor or oseltamivir. And this again the same suggested the filgrastim granulocytic colonist immunity factor. So after starting initial empirical antibiotic or antiviral, how it covered subsequent modification of initial antibiotic regimen. So after 2 to 4 days of empirical antibiotic therapy, we see if this patient is high risk patient and on having unexplained fever. If a fever persists but patient is stable, then there is no change in antibiotic. We should continue the same empirical antibiotic. But if the fever differs and the culture is negative, then continue antibiotic until absolute neutrophil count is more than 500. But in low risk patient, when there is an unexplained fever, if the fever is persists but clinically patient is unstable, then the hospitalized give a IV antibiotic. If the fever already persists and the culture negative, then continue antibiotic until the absolute neutrophil count is more than 500. And antibiotics should be modified according to the culture and the infection site, and continue for 7 to 14 days or 2 days after the patient has been applied, or there is documentation of a narrow recovery, that is your absolute neutrophil count has increased to more than 500. So when there is documented infection, the antibiotics should be modified as per the culture and infection site. And in case that does not respond, in non-responder, continue antibiotic for 7 to 14 days. In case of non-responder, we should again see or investigate again to see the potential source of infection. So we we should do CT and MRI imaging and repeat culture and biopsy, and do the antibiotic doses should be increases if required, and we should add an antifungal above the antibiotics, and otherwise we can broaden the coverage of antibiotic, and we should train the infection site if we find again. So what are the differential diagnosis that can differential diagnosis that can suggest that the for the persistent fever. So for persistent fever, the differential diagnosis are the transfusion reaction or a medication allergy or a medication toxicity or any tumor related fever or fever related to any bleeding or other drugs. So when we should give the antibiotic, antibiotic should be given. There are different studies that suggest antibiotics should be started as soon as possible. So early studies of the patient with neutropenic fever documented mortality rate of up to 70% if the initiation antibiotic was delayed. So the guideline of the Infectious Disease Working Party of the Japan Society of Hematology Oncology and Northern Ireland Cancer Network, they suggested that empiric broad spectrum antibacterial therapy be initiated immediately after the blood cultures have been obtained and before any other investigations have been completed. And international guideline again advocate the administration of empirical antibiotic therapy within 60 minutes of a presentation of a neutropenic fever. So these are the IDSA guidelines, but how India's ICCM guideline 2019 suggests. So if a patient having broad-spectrum infection, we should give a broad-spectrum antibiotic, but in broad-spectrum infection, we should not give the doripenem or ertapenem. This is not recommended. And vancomycin or teicoplanin can be added if patient having a suspected IV catheter infection, skin septic infection, or patient having a colonizer infection with the MRSA, or a blood culture that is positive with gram-positive foci, severe mucositis, or hemodynamically unstable patient are admitted from the home or OPD. In this patient, we should add vancomycin and teicoplanin. And in broad-spectrum infection, we can give imipenem or meropenem, along with we can give colistin or a poly B, colistin or polymyxin B in high-risk patient having resistant gram-negative infection. So in high-risk this for gram-negative infection, resistant gram-negative infection. Okay, these are the acute leukemia persisting, presenting to the ICU, or leukemia or lymphoma. On these are already on beta-lactam or beta-lactam inhibitor, that is amoxicillin carbonate, or your cephalosporin or piperacillin tazobactam. And along with this, if patient already having aminoglycoside, these are shifted from what, and these are having a leukemia or lymphoma, we should again change to colistin or poly B. So patient already previously prescribed antibiotic in past 1 month, then we can change to escalate to colistin or poly B. And the patient having refractory shock or carbapenem therapy already in the patient was taking in the one, then we should escalate to colistin or poly B. So ICC can suggest about the empiric antifungal. These are should be considered in allogenic hematopoietic stem cell transplantation, severe mucositis or with diarrhea, prolonged anticipated neutropenia more than 10 days, or worsening while patient on BLBLI or carbapenem image, or history of invasive fungal infection, or still patient receiving steroid for more than 3 or 21 days, or new onset long infiltrated with HRCT. So first line, we should give echinocandidates, caspofungin, but this should be avoided in patient having lung liver disease. In these cases, we can give the anidular micafungin. Again, IV voriconazole, this should be given in patient having subproven or probable aspergillosis. Liposomal amphotericin B in patient having mucormycosis, and we should confirm by CT scan, or we should do beta glucan or galactomannan of the serum or bronchial lavage. Again, fungal culture and biopsy we can take whenever possible. In CNS or eye infection, we can there are non-penetrable cannot penetrate. So in these cases, CNS and eye infection, we can go with the liposomal amphotericin B and the procyclizine. Empiric antiviral, again, acyclovir, we can usually this is empirical antiviral is not recommended, but whenever it's required, we can give the acyclovir for herpes zoster or herpes simplex if a clinical lab or there is evidence of infection. Clinical lab evidence of infection. Again, ganciclovir for cytomegalovirus virus reactivation or in diarrhea or pneumonia, not responding to initial antibiotic or antifungal therapy. In patient on T cell depleting agent, fludarabine or purine analog or rituximab, and patients on high dose of steroid with diarrhea. So in this 3-4 condition, we can give antiviral ganciclovir for the cytomegalovirus. But there is no specific treatment against the influenza or parainfluenza viruses. Again, the pneumocystis PCP prophylaxis, that given the sulfamethoxam trimethoprim in patient having a hypoxic respiratory failure without radiological evidence of pneumocystis pneumonia, or in patient having with a hematopoietic stem cell transplantation, or a patient having high dose steroid or receiving T cell depleting agent. In this patient, we can give empiric for the PCP pneumonia. And antimalarial are only given if we found the positive cases. So again, antibiotic modification as per the ICC guideline, once pathogen identified, de-escalate to susceptible antibiotic and according to the site of infection. treat with appropriate antibiotic based on the site and the pathogen until the febrile more than fever or count has been raised to more than 500. In patient without microbial documentation, continue empirical antibiotic until the fever when patient is affable for more than 48 hours, or absolute neutrophil count is more than 500. So when the neutropenia with continuing fever, this is defined by new onset of fever after being affable for more than 48 hours, or fever persisting for 3 to 5 days while on antibiotic therapy. So neutropenia, this is defined as a continuing fever. Continuing fever, that is affable while again fever, new onset of fever after being affable for more than 48 hours, or fever persisting for more than 3 to 5 days while on antibiotic. So in this part, we should go about how to go about in this patient of continuing fever. We should search for infection like respiratory pneumonia, CLABSI or COPD, or Clostridium difficile infection, or we should look for sinusitis. Or repeat blood culture set and from any other or any other suspected site of infection. We should do imaging like CT and MRI to find any other site of infection like lung, brain, or sinus, or abdomen, or pelvis. And when we find a particular site, which drainage of the suspected site of should be done, and we should send for the stent and culture again, and we should broaden the or change the antibiotic. Broaden antibiotic or change the antibiotic, or we can change from the oral to IP also, and add or switch antibiotic. So this is all about the neutropenic fever. Thank you.
Thank you, Sanjeev sir.
Thank you.
Now we will move. Okay. Now we will move to our next session. Next class is actually on approach to tropical infections. I would like to invite Dr. Satyajit Chaudhary sir to please share your screen and proceed with the lecture. Sir, please.
Is it visible?
Yes, sir, visible. You can make it full screen.
Okay. Thank you. Good evening, everyone. So next we are going to discuss about tropical infection. Actually, it's a very vast topic, so we are not going to cover everything in just 20 to 30 minutes. So I'll be discussing about the important diseases which we encounter on daily basis in our ICUs, and we should be knowing the must-know areas. So I'm focusing only on those areas which we should know, so that in exam we can face the questions. Tropical fevers were defined as an infection that are prevalent in or are unique to tropical and subtropical regions. Some of these occur throughout the year, and some especially in certain seasons like rainy or post-rainy seasons. And most common infections include which we encounter are the dengue, rickettsial, scrub, malaria, typhoid, and leptospira. All this, not only this, also other diseases are also encountered on daily basis. So Indian Society of Critical Care Medicine recommends a syndromic approach for the diagnosis and treatment of the critical tropical infections, and it has identified 5 major clinical syndromes. So they have said we should approach in a syndromic manner rather than an individual basis. So they have classified broadly into 5 syndromes. One is undifferentiated fever, fever with rash or thrombocytopenia, fever with ARDS, fever with encephalopathy, and fever with multi-organ dysfunction syndrome. What are the common infections coming under these categories? In undifferentiated fever category, we find malaria, scrub, leptospira, typhoid, dengue, and other viral illness. Similarly, under thrombocytopenia category, again dengue, rickettsial infections, meningococcal infections, malaria, leptospirosis, measles, rubella, and other viral exanthem are seen. And diseases which are associated with ARDS are scrub ARDS, falciparum malaria, influenza, leptospirosis, hantavirus, malidiosis, CAP due to Legionella, and Streptococcus pneumonia. Similarly, febrile encephalopathy includes encephalitis caused by herpes virus, Japanese encephalitis, meningitis caused by Streptococcus pneumonia, Neisseria, Haemophilus influenza, scrop, cerebral malaria, typhoid encephalopathy, etc. And the diseases which are associated with multi-organ dysfunction are any bacterial sepsis, falciparum malaria, complicated cerebral malaria, leptospirosis, scrub, dengue, hepatitis, antivirus infection, and macrophage activation syndrome. Now, how will we approaching these diseases? They have given a broad guideline for the treatment of these tropical infections. First, those which are associated with thrombocytopenia here, only conservative, no specific therapy is indicated. Especially, we should avoid aspirin and other anticoagulants, and here no role of steroids are there. Similarly, diseases which are associated with jaundice, here same empirically we should start with ceftriaxone and doxycycline. Same in case of fever associated with renal failure patients. Here, additionally, we should, if required, go for renal replacement therapy. Similarly, fever with encephalopathy patients should be started empirically with ceftriaxone, and along with that, acyclovir should be added. And if patient is showing features of raised ICP, then ICP lowering measures should be started immediately. And if seizure, then anti-seizure measures or prophylaxis should be added. Similarly, fever associated with ARDS, here additionally we need to go for macrolide like azithromycin, and also we should take care of H1N1 influenza. For that, we need to add oseltamivir. Now coming to these infections one by one. First, we'll be discussing our rickets cell group of infections. These are obligate intracellular gram-negative coccobacilli, usually transmitted by tick, mite, flea, or louse vectors. They take on a characteristic red color when stained by Giemsa or gymnast stain. So they are broadly classified into three groups: Rickettsia, Orientia, Ehrlichia. So these are the organisms which come under rickets cell infection group. They are mainly spotted fever group, like Rocky Mountain spotted fever, rickets cell fox, typhus group. Here, these are most commonly encountered in our setup, like scrub typhus, and other involve Q fever, human monocytic, human granulocytic, ehrlichiosis caused by Coxiella burnetii. Now, scrub typhus, here the causative organism is Orientia sussugamsi, and the vector is the larva of trumbiculate mite, and it's the most common of all rickets cell infection. And in 50% of the cases, we found the typical or characteristic scar. And here the important thing to remember is immunity doesn't develop. So the patients may get repeated infection due to incomplete development of immunity against the scrub typhus. Now, what is the pathophysiology? Mainly the organism affects the vascular endothelium with subsequent injury, and the organs like skin, liver, kidney, brain, resulting in multi-organ failure. Intense infection of endothelium of pulmonary microcirculation leads to pneumonia, edema, and ultimately leading to ARDS and hypoxemia. Cell-to-cell spread of rickettsia in body in hundreds of contiguous infected endothelial cells manifest as maculopapular rash. Typical rash are seen in the case of scrub typhus. And platelets get consumed, leading to thrombocytopenia. Also, a typical feature is hyponatremia, that should be remembered. DIC is less common in case of scrub typhus. Post-immunoresponse determine clinical severity, and other clinical predictors include old age, G6PD deficiency, diabetes, and male sex. Now, coming to clinical features, here the incubation period varies between 6 to 20 days. It usually begins as an acute, non-specific febrile illness, often accompanied by headache, myalgia, nausea, vomiting. After 3 to 5 days of illness, the rash starts to appear. Scar at the site of ectoparasite bite with local or generalized lymphadenopathy may be seen. and the lymph nodes are usually tender in these cases. And SCRA may be only clinical sign that differentiates crop typhus and tick-borne rickettsia from other infectious diseases, including murine typhus. So these are the typical SCRA marks which we find in case of scrub typhus patients. Gastrointestinal symptoms occur in about 2/3 of the patients, and they typically involve the mucosa, causing hemorrhage, multiple erosions, ulcers, and GIT. And focal neurological deficit is also seen, leading to meningitis or meningoencephalitis, scrub encephalitis. On CSF analysis, we found increase in the cell count, increase in protein in about 1/3 of the patients, and the sugar concentration is usually low. And how are going to diagnose? Well, Felix is got poor sensitivity and specificity. The gold standard here is indirect fluorescent antibody assay, and ELISA for immunoglobulin G and IgM antibody. Here, the sensitivity and specificity approaches to more than 90%. Treatment, first line of treatment is doxycycline, 100 mg twice daily for at least 7 days, and azithromycin or rifampicin or chloramphenicol are alternatives in case of children and pregnant ladies. Next, we'll be discussing about leptospirosis. Here the causative organism is Leptospira interrogans, and the source of infection is mostly direct contact of skin or mucosa with water contaminated with urine or body fluid of an infected animal. And the rodents are the most important reservoirs for maintaining this transmission. Coming to pathophysiology, leptospires multiply in the small blood vessel endothelium, resulting in damage and vasculitis, and the clinical manifestation subsequently. So the main pathology involves cytokine storm because of release of various cytokines and interleukins, causing hepatic damage and renal injury, causing interstitial nephritis. So mainly hepatorenal system gets involved, and also vascular. Clinical features here, the incubation period lies between 5 to 14 days, and the manifestations are usually biphasic, like two types. One is anicteric and another is icteric leptospirosis. Icteric is called Wells disease. In anicteric, there occurs abrupt onset of fever, chills, headache, myalgia, pain abdomen, conjunctival involvement, and transient skin rash. And in case of icteric leptospirosis, which occurs in about 15% of the patients, characteristic feature is jaundice, proteinuria, hematuria, oliguria, ranuria, pulmonary hemorrhage, air disc, and myocarditis is seen. Now, how we are going to diagnose leptospirosis? Clinical picture is peripheral smear will find anemia, leukocytosis, and elevated ESL, and thrombocytopenia is present in most of the patients. Urine analysis shows erythrocytes, leukocytes, granular or hyaline cast, and proteinuria. Bilirubin level may rise profoundly, and there may be rise in ALP level and modest increase in the enzymes, which are usually below 200. And blood urea and creatinine levels are also elevated because of renal involvement. And CPK level may be raised or may be normal. But if it is elevated, this helps to distinguish leptospiral hepatitis from viral hepatitis. And a specific diagnostic tool is the most commonly used method is microscopic agglutination test using live pathogenic leptospira as antigen. Also, IgM ELISA test is done, and isolation of leptospira from blood, urine, or CSF is a definite proof of the infection. And PCR assay is sometimes done to diagnose leptospirosis. Coming to treatment, first line of treatment is penicillin G. We use about 1.5 million unit 6 hourly for 7 days. There is a level 1 recommendation. Alternatively, third generation cephalosporin and oral doxycycline is used in case of uncomplicated infection. plasma exchange, corticosteroids, and IVIG in selected patients may be tried in whom the conventional therapy cannot be applied. Now coming to next most common infection, that is dengue. Now the causative organism is the virus, flavivirus. 4 serotypes are usually seen, 1, 2, 3, 4. And the vector is Aedes mosquito and is endemic throughout India with the recent resurgence of epidemics over the past 2 decades. As we are commonly encountering this infection nowadays, very common. Coming to pathogenesis, usually there occurs cross-reaction. Anti-dengue antibodies from previous infection enhance newly infecting strain with viral uptake of monocytes and macrophages, and leading to amplified cascade of cytokines and cytokine storm because of complement activation. There occurs endothelial dysfunction, platelet destruction, and consumption of coagulation factors, plasma leakage, and hemorrhagic manifestations, the characteristic manifestation. Clinical features, incubation period is 4 to 10 days, and mainly the clinical features are divided into 4 types. Accordingly, dengue is also divided into 4 types. One is dengue fever, that is simply associated with fever, headache, retroorbital pain, myalgia, rashes, and arthalgia, not associated with any hemorrhage. When it is associated with hemorrhage, it's called dengue hemorrhagic fever. Here the platelet count drops to sometimes to below 10,000 level, leading to skin, mucosal, and GI bleeds. Also, there occurs third spacing and rise in hematocrit. What is dengue shock syndrome? When it is dengue hemorrhagic fever is associated with profound decrease in blood pressure, weak pulse, cold clammy extremities, and pulse pressure is below 20 millimeter mercury. That is an important feature for diagnosing dengue shock syndrome. And what is expanded dengue syndrome? When it is involving many organs like brain, heart, liver, kidney, airways, and also associated with hemophagocytosis that we call expanded dengue syndrome. Going to diagnosis, rapid CAT test is used nowadays, NS1 easy antigen, IgM, and IgG, and sensitivity approaches to 90% and specificity is almost 98%. Treatment, only conservative management is done. Ascertaining fluid infusion is just sufficient to maintain effective circulation during the phase of plasma leakage, and this should be guided by serial hematocrit determination, and blood transfusion is done only with overt bleeding or rapid fall in hematocrit. Now, something about fluid resuscitation. It should be guided by dynamic assessment of hemodynamic status, preferably with continuous intra-arterial BP monitoring. Echocardiography and lung ultrasound help in this case, and taking decision about fluid administration by checking the IVC diameter. Hematocrit can be measurable in the lab to assess prognosis, but it should not be used to guide fluid management. What are the adjuvant therapies used in case of treatment? Steroid and IVIG are usually not recommended in this phase. No evidence regarding the use of recombinant factors also. And also there is no place for use of prophylactic antibiotics during first 4-5 days of fever if dengue is suspected, even if there is presence of effusion and ascites. Now, in pregnancy, vertical transmission occurs up to 5 weeks before delivery, and so leading to dengue in the newborn. Infections earlier in first or second trimester also can lead to abortion and later low birth weight, leading to increased risk during delivery. So early admission and close follow is advised in case of pregnant lady getting infected with dengue. And fluid volume for critical period. Yes, the target is a bit different for a pregnant mother. It should be calculated based on the weight prior to the pregnancy weight. Now, malaria. Here the causative organism is Plasmodium protozoa, mainly Falciparum vivax, and in Odisha, specifically Plasmodium malady is also found in some patients. The vector is the Anopheles mosquito, female Anopheles mosquito, and species are unevenly distributed across India. But specifically in this eastern India, like Odisha, Chhattisgarh, West Bengal, they mostly, majority of the cases we found in this belt. In some also, in Karnataka area also, there is some endemicity is seen. Pathophysiology, mainly there occurs mechanical microcirculatory obstruction caused by cyto adherence to the endothelium of the RBC loaded with the parasite and causing sequestration. So ultimately they lead to intravascular hemolysis. So these are the reasons for which there occurs all the typical manifestations of complicated malady. So what are the clinical features? Besides the typical manifestations of chills and rigor sweating, there are others manifestations which indicate severe malarial infection like severe anemia, hypoglycemia, metabolic acidosis, acute renal failure, ARDS, shock which is called algid malaria, DIC, hemoglobinuria, and hyperparasitemia. Now we are going to diagnose. Microscopically, thick smear, thin smear are taken. Thick smears will diagnose the parasite, and the thin smear will isolate the species. And QBC, which we use most commonly, QBC and ICT. ICT is the rapid diagnostic test. It is a histidine-rich protein lactate dehydrogenase antigen-based immunochromatography test. Here the sensitivity and specificity approaches 95%, and if two ICTs are negative, then malaria is ruled out. Treatment drug of choice is artesunate, dose 2.4 milligram per kg IV bolus at admission, followed by repeat dose at 12-hour and 24-hour interval, followed by once daily for 7 days, plus doxycycline 100 milligram per oral 12 hourly can be given. Alternatively, quinine 20 milligram per kg loading dose followed by 10 milligram per kg IV infusion 8 hourly plus doxycycline 100 milligram per oral 12 hourly. Clindamycin is recommended in place of doxy in pregnant women and children. And exchange transfusion is a treatment option if there is profound parasitemia of more than 10%. And it's not recommended with artesunate. If the patient is getting artesunate, then excess transfusion is discouraged. Now coming to melanosis, it's caused by Burkholderia pseudomallei. Burkholderia mallee is the agent of equine genders, and various species from Burkholderia cepacia complex are nosocomial pathogens for immunocompromised patients and cystic fibrosis individuals. In October 2012, the Burkholderia pseudomallei was upgraded to a Tier 1 select agent by the Center of Disease Control and Prevention. This is the mode of transmission. The predominant mode is percutaneous inoculation during exposure to wet season soils or contaminated water. Inhalation, aspiration, and sometimes ingestion also leads to development of melioidosis. And transmission related to animal exposure and person-to-person transmission is very rare. And fulminant pneumonia cases are seen due to inhalation of the pathogen. The unique feature of melioidosis is the easily aerosolized in favorable weather condition, intrinsic resistance to standard antimicrobial agents, and the lack of vaccination. And a diverse range of disease presentation are found that leads to delay in the diagnosis, particularly in the non-endemic areas. This is the clinical picture. Here we can see the most common manifestations are pneumonia and localized skin infection, like rash or abscesses seen. But pneumonia is the most common form seen both in bacteremic and non-bacteremic cases. Over half of all patients are bacteremic, and up to a quarter can present with septic shock, as we can see in the table. So the environment is lungs, pneumonia, skin, genitourinary, osteomyelitis or septic arthritis, soft tissue abscess. And in non-septic shock cases, skin infection and non-evident focus, neurological involvement is also seen, but it's very rare. Diagnosis, appropriate clinical samples should be taken in order to diagnose burkholderia, like blood, sputum, urine, swab of an ulcer, skin lesion, abscess fluid, throat swab, rectal swab, all can be taken. And culture is the mainstay of diagnosis. Acetone agar, which contains gentamicin, or Acidoun's liquid transport broth, which contains colistin, they allow selective growth of Burkholderia pseudomeli. And microscopic gram stain of sputum and abscess spurs may reveal gram-negative bacilli of Burkholderia pseudomeli. They have a characteristic bipolar staining, which is called septic in appearance. And serological testing alone is not a reliable method of diagnosis. Sometimes you need to take help of radiological imaging to diagnose Burkholderia abscess, sometimes cerebral abscess, or all those cases which are usually not diagnosed. Coming to treatment, these are intrinsically resistant to penicillin, ampicillin, and first and second generation cephalosporin, streptomycin. So the main therapeutic options include beta-lactams, specifically ceftazidime is very useful in treating Burkholderia infection. And carbapenems, trimethoprim sulfamethoxazole, and sometimes doxycycline is also used. And to prevent mortality from severe illness associated with melioidosis, 2 weeks of IV rigorous antibiotic therapy followed by oral antibiotic eradication therapy is advised. Primary parenteral agent in non-critically ill patients without skin infection is ceftazidime. But in critically ill patients and neurological involvement is there, then we should prefer meropenem at a higher dose, say 6 grams per day in 3 divided doses, or we can take in continuous infusion also. And adjunctive antibiotic for non-pulmonary focal infection, we use trimethoprim sulfamethoxazole, cotrimoxazole, and also source control should be carried out simultaneously. Now coming to enteric fever, is the causative organism is Salmonella typhi, cerebral paratyphi A, B, or C. Transmission is usually focally contaminated food and water, and is most prevalent in urban areas with high incidence seen in case of children of 15 years or younger. Here the bacteria spread throughout the reticuloendothelial system and in areas of greatest macrophage concentration like Peyer's patches in the tonsil. Incubation period is 1 to 14 days. Manifestation varies as in different weeks. First week, the main feature is the fever, headache, and relative bradycardia, sometimes seen. In second week, pain abdomen, diarrhea, constipation, hepatosplenomegaly, encephalopathy is seen. In third week, intestinal bleeding, perforation, and multi-organ involvement is seen. Diagnosis by typhoid is a rapid diagnostic test. Vital is usually non-specific, and blood culture is the gold standard for diagnosing a typhoid patient. But usually it is carried out the first week only. The blood culture will diagnose typhoid infection, and vital test usually done in the second week of fever. Bone marrow culture is a sensitivity of 80 to 95%. But problem is it may remain positive even after 5 days of treatment. Treatment, the first line is ceftriaxone, and azithromycin and ciprofloxacin are the alternative. And here the steroids should be considered in selected cases with encephalopathy, hypertension, or DIC. It has got some role in steroids. And next, Japanese encephalitis is caused by a virus. It's the same name. Vector is the Culex trianero, incus, prevalent in mainly southern, central, and northeastern India states like UP, Haryana, Bihar. The virus reaches the CNS through leukocytes and affects various parts of the brain to cause vascular congestion, microglial proliferation, formation of gliomesenchymal nodules, focal or confluent areas of cystic necrosis, and cerebral edema. Here the incubation period is between 6 to 8 days, and prodromal period there occurs fever, headache, vomiting, myalgia, followed by neurological involvement, which ranges from mild confusion to agitation, which may ultimately lead to overt coma. And Parkinson-like extrapyramidal signs are also common, including mask-like faces, tremor, rigidity, coordinated movements may also be seen. Here the diagnosis is done by mainly IgM, ELISA serum, with sensitivity around 90% and specificity more than 95%. Also, CSF sample can be taken and for diagnosis, and which has got a specificity of about 100%. Treatment mainly supportive treatment like ABC, seizure control if it is there, and management of rest intracranial pressure is carried out. Thank you.
Thank you for the extensive discussion, Sajid sir. Without any delay, I would like to welcome Dr. Rohit Patnaik sir to speak about approach to a septic patient with shock. Dr. Rohit sir is associate professor in Department of Critical Care Medicine, IMS and Some Hospital, Bhubaneswar. Rohit sir, after you, please start your presentation. Sajid sir, you can unshare your presentation so that Rohit sir can share his screen.
I think Samir should be presenting.
Okay, sir.
There was a change, na?
Okay. Sorry for the glitch. I beg pardon, and now I want to welcome Dr. Samir Samal sir to start his presentation. He's associate professor in IMS and Some Hospital, Department of Critical Care Medicine. Samir sir, please share your screen and start your presentation.
Hello everyone. So am I audible and are my slides visible?
Yes, sir, you're audible and your slides are visible. Please proceed, sir.
Okay. So I'm going to present on fungal infections. So I have divided into candidiasis, mucor, and aspergillus. Okay. So to start, invasive candidiasis, it can be candidemia and deep-seated candidiasis, tissue candidiasis. So these are the epidemiology in Candida. Fourth most common bloodstream infection in ICU. So why it is important? Because it has very high mortality. There are many now new non albicans Candida species. So because there is more resistance now emerging, so that is why they have become very. It has come to the forefront. So it has become more common in ICUs, as I told you. Fourth most common in bloodstream infection in ICU with very high mortality. You can see here, although incidences were less, but the mortality is very, very high. So this is your CM Candidemia network, 27 centers they have done. So mortality was overall 40%, attributable 20 to 28%. So there is very high incidence we have generally seen in younger population than to the compared to the world. Early infection, lower Apache score, even with lower Apache score, they develop these infections. There is high incidence of azole resistance. So very high mortality. Okay, and we have found around 31 species in India. So again, this is the incidence of various species. So this is the mechanism. Where this is the intestine. We know it is a colonizer, and it is a commensal found in the gut, in the skin tissues of our in the normal human beings. So only when there is immunocompression and there is a breach in the mucosa, then there is a chances of candidemia or deep-seated candida infections. So as we see abdominal cavity, there is here we can see this is the blood vessels. Okay, so here generally when there is a breach or when there is immunocompromise, so there is adhesion and colonization, hypal penetration and invasion. This is the way they invade. Okay, then there is vascular dissemination, and here there is biofilm formation on the cannula. So this is basically how it takes place. Okay, so in abdominal cavity, they can cause abscess, pancreatitis, peritonitis, in bone, osteomyelitis, brain, encephalitis, abscess, eye infections, heart, endocarditis, kidney. Also, they can cause pyelonephritis and renal abscess, liver and spleen, again abscess. Okay, focal abscesses they can do, Candida infections. So what happens in pathophysiology is that they the Candida species they secrete aspartyl proteases and phospholipidase that activate the innate immune response. Okay, so that it is that helps in fungal tissue invasion and organ damage. There is also release of Candida lysine. It causes epithelial cell damage and activates your chemoattractants. Okay, so effective adherence and invasion of the Candida species in endothelial and epithelial cells enable them to disseminate into the bloodstream. They have agglutinin like protein 3. Okay, Candida albicans specific adhesion and invasion in case of albicans. Okay, so remember these points to write in pathophysiology. So these are the causes. They cause invasion, and there is then infection. There is dissemination takes place. It also facilitates biofilm formation on implanted devices, which I showed you. Okay, this is a major source of long-term candidemia. So patients with autosomal recessive deficiency in the CLR pathway, the CARD9, just remember CARD9, they have high susceptibility to fungal infections, and CARD9 deficiency, they have very prone to CNS infections. Okay, and null mutation in this gene they cause mucocutaneous but not invasive candidiasis. They are more prone to mucocutaneous candidiasis. So a 50-year-old female, ileal perforation, admitted to ICU, drowsy, vitals unstable, respiratory failure, known diabetic, hypertensive. So mainly we know that the most common factor for your Candida or any fungal infection, the most common factor, very important factor is your immunosuppression. That is present most of the times. That is the main cause of your fungal infections. So, and any GI with GI surgery or GI problem, because as I told, it is a commensal in our gastroenteral tract, the Candida. So whenever there is anything related to GI with immunosuppression history, like diabetic for the last 9 years, okay, so patient was on TPN, and so these are all risk factors. Just remember, your mind should go towards fungal infection. Okay, so sputum P% as a vacuum combination. Ileal leak was repaired on third day. Vital stabilized, PFSO improved. Fifth day again she had a fever, leukocytosis, blood culture was sterile. Antibiotics were escalated to meropenem. So what issues we have now? What are the chances of invasive candidiasis in our patient? Can we predict invasive candidiasis in our patient? What are the risk factors? What investigations to be sent? Culture, okay, or non-culture based, how frequently, and if patient needs fungal prophylaxis, preemptive or empiric therapy. So why it is important to detect the species is because your Paracelsus and Flusai, they are less virulent than your albicans tropicalis. Okay, so Candida species also we are seeing generally shift. Earlier it was albicans and all. Now generally we are seeing auris. It is very resistant, highly resistant to azoles and all. So depending on the species, also drug susceptibility varies. So it is important to know the species of the. So as I told, Candida auris. Okay, very high mortality. So these are the various studies regarding Candida auris, their incidence and their mortality. So these are the risk factors. The point in the red are the present in our patient, but generally these are the risk factors. Already multifocal Candida colonization, diabetes mellitus, hemodialysis, pancreatitis, high Apache score, steroid therapy, extremes of age, prolonged ventilation, central line in situ, prolonged stay in ICU, patient on broad spectrum antibacterial, TPN, major surgery, trauma, immunosuppression. These are the risk factors for your invasive candidiasis. So, what are the various scores or methods to suspect Candida? Colonization index, Candida score, predictive rules with clinical risk factors, okay, and also a score for severe pancreatitis. So, coming to the Candida score, these are the variables for Candida score. So, clinical sepsis score if present is 2.
Amir sir,
Huh.
sorry for interrupting, sir. There is a pop-up coming on the screen actually. So can you hide that?
Yeah.
Thank you.
So this is the Candida score. Clinical sepsis is 2.2. TPN is 1. Surgery is 1. Multifocal colonization is 1. So how do we know if it is score greater than 3? Then generally patient would benefit from antifungal treatment. Okay, and if it is less than equal to 3, then it is highly improvable. So clinical prediction rule as another score. So these are the mechanical ventilation greater than 48 hours, any systemic antibiotic, or at least one of TPNRRT, major surgery, pancreatitis, steroid. Then okay, so this is another score. So what investigations are to be sent? So generally, as we know, for fungal, it is better to send means blood culture is always the mainstay. Culture, sending cultures during fungal cultures. What you have to take care is that they have a very long time to positivity, of median of around 2 to 3 days. Okay, so sometimes we may not get, and their colony count is very less, around one only. Like 10 to the power 5 is for bacteria and all, they have colony forming unit very late. In Candidemia, when Candidemia is present, the colony forming unit can be only one. So that is why we have to send very high amount of blood volume for sending cultures. Like we send 10 ml in 2 bottles or 20 ml in 2 different bottles for blood cultures for our bacterial infections. For fungal infections, it is generally advisable, if you are suspecting a fungal infection, it is advisable to send 30 to 40 ml of blood in each well for your fungal culture. And also we have to go for a specific fungal culture in specific media. You have to mention that to our microbial lab. Okay, so what are the various methods? As I told, direct microscopy, rapid and cheap, we can see fungal elements on tissues. Then culture, multiple specimen have to send, you have to send repeat, because as I told, your colony count is very less, you may have to repeat what 3 days. Repeat cultures have to be sent every 2 to 3 days, means consecutively for 3 days, to have more higher chances of getting a fungal infection. So where it is very slow, as I told you. So histopathology is the best. It is very but there has to be a surgery or something. And a specimen has to be taken to confirm from histopathology whether it is invasive disease present or not. Galactomannan, it is specific for sensitive species for Canada albicans, not others. Beta 1D glucan can also detect, and then again there is PCR. Okay, but all are quite sensitive but very less specific. So we have to always bring in clinical suspicion and judgment while starting treatment for Candida infections. So that is where the terms that are present, and those preemptive, prophylactic, will come to that. It has already been discussed, I know, by Dr. Sanjeev, but I will again tell. So blood culture for Candida isolation, as I told you, 40 ml and all. So median time to positive 2 to 3 days, maybe long even. So these are the other available to know what kind of species like Malditoff can be seen in the identification species. Identification can be done in few minutes. Okay, then sequencing PNA fish. So these are other available methods to detect the species. Okay, one is our blood culture, which takes 3 to 4 days. Okay, so PNA fish and Malditoff. Malditoff is the newest thing in the, so you have to keep it in mind, Malditoff. Okay. So biomarkers for diagnosis of invasive candidates, beta D glucan, I already told, Candida PCR, very sensitive, procalcitonin. So Candida PCR is more sensitive, better than beta glucan, less expensive, but specificity is low. For all the tests of Candida, specificity is very low, but it is very highly sensitive. Okay, so all this not yet standardized, but these are the various available methods. So our patient, does he need a prophylaxis or preemptive or empiric therapy? Okay. So this is how it is divided: prophylaxis, preemptive, empirical, and targeted. So prophylaxis is that only risk factor is present, but biomarker negative, clinical sign negative, mycology negative. Like in bone marrow transplant patients, immunosuppression, severe immunosuppression in autologous transplant, bone marrow transplant patients, in hematological malignancy, neutropenia patients, bone marrow suppression. In them, you may go for those are the risk factors, and if they are non-diabetic, they are on steroids or some other, they have many risk factors present. In them, you may start prophylactic. Preemptive, risk factor is present, a biomarker is positive, clinical sign may be there, may not be there, and but cultures are negative. So that is called a preemptive, risk factor and biomarker. Now, empirical is risk factor, clinical signs, but biomarker is negative and culture is negative. So that is when we tell it is empirical fungal therapy. Targeted when your cultures are positive and all other everything are positive. Biomarker may or may not be positive, but your mycology, your culture or histopath is positive. Okay. So this is prophylaxis, preemptive, empirical, targeted. Okay. So our patient now falls in risk factor is definitely positive. Yet now we don't have any biomarker, but clinical signs and all definitely positive, we may go for empiric fungal therapy. Okay, so susceptibility to various drugs. These are we see Cruci is resistant to our normal fluconazole. With the first azoles generally we try. So Cruci is difficult, or is again resistant to most of the azoles. Cruci is again resistant to azoles. Albicans and tropicalis, they're sensitive to azoles. So when to go for prophylaxis, I have already told when to go for prophylaxis. In severe acute pancreatitis, debatable. Okay, unless there is very not high suspicion, there is prophylaxis in severe acute pancreatitis, debatable. So ideal prophylaxis candidate: GI anastomotically, neutropenic BMT, liver transplant, only transplant. So prophylaxis sources, what can we give? We can give fluconazole 400 mg daily. We can give posaconazole 200 mg 3 days, or echinocandins also we can give. So antifungal agents, they generally work on where they work: cell wall echinocandins, cytoplasm azoles, DNA antimetabolites, 5-fluorocytoside, cell membranes, polyenes. Okay, so this is where they work. So factors responsible for increased mortality: decreased awareness, delayed diagnosis, inadequate, or inappropriate. So hit it right, early and hard. Empirical antifungal in our case, as I told you, persistent fever without obvious source, but mostly here we had an abdominal source. Fever not responding to antibiotics. We have already escalated to meropenem, but response is not so good. So we should suspect Canada colonization. So what agent we should choose? Like that depends on species, what species we have developed, cultivated in the cultures. History of azole exposure: if there is history of azole exposure, it is better to go for echinocandins. So this is in treatment. Okay, so local epidemiology and susceptibility pattern, that is always you have to cater to that. Your local antibiogram. Severity of illness: if it is very severe, shock is present, you have to go for echinocandins. If shock is absent, you may have to go for azoles. You have to always, whenever there is a candida infection present in your blood, it is positive, you always have to look for disseminated candidiasis. Okay, you have to go for a screening of eye. So strategy: invasive candidiasis is proven or probable. If hemodynamically unstable, we go for unstable, yes, we go for echinocandins. Okay, or liposomal amphotericin B. And if hemodynamically stable, then if it is again risk of glabrata, cruci, or oris, again you have to go for echinocandins. If no, we suspect albicans and tropicalis, we can go for fluconazole. So fluconazole in hemodynamically stable patients, no previous exposure to azoles. Echinocandins, unstable patient, recent azole exposure, neutropenic patient. Amphotericin B, echinocandins, when it is very costly, not available, or in urinary tract infections where the echinocandins are not excreted in the kidneys, they do not get concentrated in the kidneys. So renal infection or urinary tract infection with fungal, multifocal fungal, where you have to target fungus in the urine. Generally, if there is a fungal growth in the urine catheter, in urine culture, it is generally colonizer. We just need to change the Foley's catheter. But if you are suspecting multifocal candida infection and there is a pyonic abscess in the renal abscess because it is a fungus, then maybe you have to treat that. Then you have to go for azoles or amphotericin B because echinocandins will not work there. So de-escalation: echinocandins to fluconazole if it is stable, or to voriconazole when it is sensitive, cruci or glabrata. Duration of therapy: actually, whenever they get a blood culture positive for fungal infections, you have to always, candida infection, you have to go for culture every second day. Same cultures every second day, and once you get the culture negative, from that day you have to give 2 weeks. So 2 weeks after last negative blood culture. Okay, that is the duration of therapy. So central lines one, there is a culture positive with central line in situ, you have to change the central and go for a new central line. As I told, biofilm formation takes place, and that takes longer. Gradual dissemination of candida takes place from that catheter, so that should be changed. Then for endophthalmitis, we have to make the treatment is amphotericin B and flucytosine for 4 to 6 weeks, and partial vitrectomy may be needed. So suggested therapy again: first line fluconazole, alternative amphotericin B, depends, and your European says echinocandins, others says fluconazole, depending on the shock and all. Okay, stable patient fluconazole, severe sepsis, echinocandins. Triazoles may be preferred in the treatment of meningitis, endophthalmitis, and urinary tract candidiasis because echinocandins does not work. cost-effective resource also matters. So critically ill patient, fungal infection suspected or proven, risk factors, prophylaxis, preemptive, empirical. This is the flow chart. So Candida species detected, we have to give echinocandin. Once it is identified, we can change. If it is albicans, we can go for fluconazole. Tropicalis, we can go for fluconazole. Paracelsus, again we can go for fluconazole. But glabrata and Flusei and Auris, it has to be echinocandin first line. If any problems are there like cost problems, then we can go for amphotericin B. So Candida and acute pancreatitis, very poor prognosis. Okay, if fluconazole is susceptible, if there is high risk patient, then we may give iodine antifungal in stable febrile patient. CNS candidiasis, better to provide drug in intraventricular device because penetration is very low. For CNS candidate, to always add flucytosine, liposomal amphotericin B, the lipid preparation 3 to 5 mg per kg and flucytosine 25 mg per kg dose 4 times daily has to be given. So after initial response, de-escalate flucytosine to 400 to 800 mg per day. Remove the infected ventricular disease. So summary, high burden, early infection, younger people, less apache in India. So predictive rules, we have to see your prediction, preemptive, accordingly you have to decide. Early diagnosis is required, mortality is very high, blood culture is the gold standard. Identification of the species is important. So not high procalcitonin may help to suspect. So procalcitonin only to just if it is low but there is fever and also that's generally it is serial procalcitonin. We cannot say for sure. It is used for de-escalation mostly. But still, if you are suspecting a high grade infection with very low procalcitonin serial values, then you may suspect a fungal infection. PCR is a futuristic test, not yet validated. Okay, immunogenetics, the new methods are going. Now coming to mucormycosis, order Mucorales, genera, your Rhizopus mucor, Rhizomucor, and all those are there. Here the hyper broad, irregularly branched, and have rare septations. Whereas how to differentiate from aspergillosis? They are narrower, they have regular branching, and have many septations. Okay, so this is how you distinguish mucor and aspergillus in microscopy. So lack of regular septations contribute to the fragile nature of hyphae. So the difficulty of growing the agents from clinical specimens. So that is why it is difficult to get a confirmative lab diagnosis of mucormycosis. So this rhizopus they produce ketone reductase, which allows them to thrive in high glucose and acidic conditions. So we generally, whenever there is a patient of DKA and you're suspecting fungal infection, it maybe there is a chance of mucormycosis. Okay. So serum from healthy, the why, how is it, the serum from healthy individuals inhibits the growth of rhizopus. So that is why if there is a immunocompromised patient with diabetic ketoacidosis, so it is seen that there was increased growth of sugar in those blood of diabetic ketoacidosis patient because of the ketone reductase. So mostly we know that mucormycosis causes rhino-orbital cerebral mucormycosis or pulmonary mycosis. These are caused because of your inhalation, the spores they get lodged in the nasal mucosa and from there the infection takes place. Generally, we also inhale that, but since we are immunocompetent, we seldom develop those infections. But those are immunocompromised, they easily get these infections. Okay, so what they happen is they get and damage the tissue and cause infarction. So infarction of the infected tissue is the hallmark of this mucormycosis. So other risk factors are desferrexamine, which chelates both iron and anovulum. They increase the risk of mucormycosis by enhancing the growth and pathogenicity. So it is a siderophore for the species of rhizopus. They increase the iron uptake by the fungus, which stimulates fungal growth and leads to tissue invasion. So these are a huge risk factor. Those are using desferrexamine. So nowadays desferrexamine use has come down because aluminum toxicity is now very rare. So those now, when those have received multiple blood transfusion, they are at risk of mucormycosis, and they have been those have been being treated with chelating agent for iron overload. Now the other two iron chelating agents, Aricerox and Deferriprone, they do not have siderophores, so they do not increase the risk of mucormycosis. So these are the various risk factors: diabetic mellitus, particularly ketoacidosis decay. So treatment with glucocorticoids, hematological malignancies are more prone to mucormycosis than your solid organ tumor, hematopoietic stem cell transplant patients, solid organ transplant patients. Those are on immunosuppression. They are high risk factors for mucormycosis. Iron overload, AIDS, again all these are malnutrition, trauma. All these are immunocompromised states. So clinical presentation, there is generally infection and necrosis of host tissue. Rhino-orbital cerebral mucosis is the most common presentation of the mucormycosis. So these patients generally present with acute sinusitis, with fever, nasal congestion, purulent nasal discharge, headache, and sinus pain. Okay, so they spread to contiguous structures here in the to the palate, orbit, and brain. Okay, and is very rapid in the course of very few days. So hallmark of spread beyond the tissues, your are tissues necrosis of the palate resulting in palatal scars, terminate destruction, nasal swelling, erythema, sinuses, facial skin. These are the symptoms patient may present with, and you may suspect rhino cerebroorbital mucormycosis. Black discharge results from necrosis of the tissues after vascular invasion by the fungus. So it can be visible to the naked eye, and you have to suspect from that. Diagnosis always has to be done by tissue biopsy. We'll come to that. So orbital involvement can cause periorbital edema, proptosis, and blindness. Facial numbness because of infarction of the sensory branches of the fifth nerve. Then, if there is spread to frontal lobe, patient may present with obtundation. If there is spread to cavernous sinus, there may be cranial nerve palsy, sinus thrombosis, and carotid artery involvement. There is also chances of pulmonary mucormycosis. Generally, it is very most common is a rhino cerebroorbital. There can also be pulmonary mucormycosis because of the inhalation of spores into the bronchioles. So, if there what it happens, heart and mediastinal involvement takes place, and from there can be hematogenous spread to other organs. Patient generally presents with fever and hemoptysis. Then other mucormycosis that can happen is GI mucormycosis. Most common place is your stomach. Then it can be cutaneous, renal, or isolated CNS, and then disseminated. It can be present everywhere. So these are the various types of mucormycosis. Now, diagnosis is always by histopathology, gold standard. Isolation cultures doesn't confirm clinical infection because even we can have. So you have to be suspicion, there has to be immunosuppression, and tissue histopathology has to show your mucormycosis. There can be PCR-based tests are also now present, and as I told, MALDI tox is also present. So clinical suspicion, DM, diabetes mellitus, ketoacidosis, risk factors are present, and depending on the symptoms, where there is to be clinical suspicion, then we have to go for a tissue biopsy. So tissue specimen can be taken endoscopically. We can also go for NCCT or CCT brain depending on the organ involvement. So to see, it is better to see bony region in CT scan rather than MRI. And for sinus involvement, carotid sinus, your sinus thrombosis, MRI is better. So HRCT, we can in HRCT chest, we can see a halo sign, ground glass attenuation surrounding a nodule. It is a angioinvasive fungi, but a reversed halo sign can also be seen. So BAL can also help in diagnosing. We can send for BAL cultures again, tissue pathology. Then organ-wise, depending on the symptoms, we can maybe go for renal biopsy or gastric biopsy. Depends on which organ. Depending accordingly, we have to send cultures and tissue specimen. So coming to treatment, mainstay of treatment is a surgery and debridement and antifungals. Both has to go together. Surgery is definitely very. If there is a massive invasion, we have to. Surgery is extremely necessary. Maybe even in lung, if it is spread to mediastinum and all, we have to go for lobectomy and all. So we have to eliminate the predisposing factors, like we have to control the diabetes, ketoacidosis. Then surgical debridement is very important. Only antifungals may not help. So antifungals what we give is liposomal amphotericin B 5 mg per kg, sometimes up to 10 mg per kg dose is also needed. So posaconazole, isavuconazole are the step down drugs. Then if there is renal involvement, you have to go for deoxycholate because your liposomal amphotericin B, it is a lipid preparation, will again not get secreted in the kidneys. So if it is renal mucormycosis, you have to go for amphotericin B deoxycholate. So step down again, we have to come to posaconazole 300 mg BD first day and then OD. Serum trough concentration of posaconazole should be checked after 1 week of therapy. Suggested trough concentration is greater than 1 mg per ml. Any fall below this may not be effective. Again, can pose high risk for the patients. So isavuconazole is a vital study, single arm study. Median treatment duration was 102 days for mucormycosis. And salvage therapy, when we know it has spread a lot, we cannot do anything, and we cannot use liposomal amphotericin B, or because of any renal function, we cannot use deoxycholate. We may go for posaconazole and isavuconazole. So posaconazole side effect that it has that carrier molecule present in voriconazole also, cyclodextrin, the chances of renal injury. Isavuconazole is very safe in that purpose. 200 mg loading dose IV, PO or PO per oral TDS for first 6 doses, that is 2 days, then 200 mg OD. So combination antifungal, we can also go for liposomal and amphotericin and isavuconazole or posaconazole, 2 drugs at a time, or with echinocandins also, liposomal amphotericin and echinocandins, but they have not yet been proven as an effective therapy. Then hyperbaric oxygen therapy, there are benefits because of your tissue invasion, but it has not yet been established, and outcome is extremely poor even in spite of surgery and antifungal therapy. And mind you, the surgeries can be devastating for the patient. There will be huge facial anatomy is distorted completely after those surgery. Huge chunk of tissues are debrided and removed. So thank you. Now I will go to the aspergillosis. That will take 5 minutes only. Is it visible?
Yes, sir, visible. Please proceed, sir.
So now coming to aspergillosis, most common species that we come across is Aspergillus fumigatus. So the various infections that it can cause is it can also cause allergic reaction in the lungs, which is allergic bronchopulmonary aspergillosis. It can cause chronic pulmonary aspergillosis. It can cause invasive pulmonary aspergillosis. IPA is invasive pulmonary aspergillosis. CPA is a chronic pulmonary aspergillosis. Generally affects individuals who are immunocompetitive or mild immunosuppression and have underlying lung disease like COPD or tuberculosis. Now, aspergilloma is a fungus ball within an existing cavity. So that is aspergilloma. Then acute invasive pulmonary aspergillosis. So this is IPA. So these are the various aspergillus situations that we can come across. So diagnosis. So pathology is again same. Immunosuppression has to be there. Then there is breakage of mucosa, immunosuppression, and there is tissue invasion. Now for diagnosis, although limited sensitivity specificity, the various for diagnosis of invasive pulmonary aspergillosis, this possible, probable, or proven. Mind you, this is not for ICU patients. This is only for those hematological risk patients. Okay, those are hematologic malignancies and all. So immunosuppressive conditions like hematological cancer, transplantation, and treatment with immunomodulating agents. So clinical criteria. So these two host criteria and clinical criteria are present, it is a possible aspergillosis. Now, if the mycological criteria, that is positive direct exam or rupture in non-sterile sites like BAL or positive galactomannan, it is a probable diagnosis. Now, if we get a positive histopath or PCR with direct exam and cultures with evidence of infection like histological or clinical, that is a proven infection. This is not for ICU. Okay, so histological examination of biopsy or surgical specimen, that is the diagnostic gold standard. Culture and non-culture methods are present. Fungal biomarkers like galactomannan, beta-T glucan are also present. PCR, these are the various methods to diagnose your aspergillus infection. The galactomannan can be sample test can be done from both BAL sample and serum, but beta-D glucan is done only from serum. Its BAL is not yet approved. So HRCT should be done to see if there is any cavity, if there is change in cavity size, then that can be because of your aspergilloma. Bronchoscopy BAL has to be done to collect specimen and send for cultures or to see any aspergillus hyphae present. So invasive pulmonary aspergillosis should be suspected in intubated patients with deteriorating respiratory condition despite broad spectrum antibiotic therapy. So these are the various tests: galactomannan, beta-glucan, and aspergillus DNA PCR tests. So if there is a high risk patient with leukemia and all, prophylactic approach, posaconazole prophylaxis should be given. Preemptive approach, serum, GM, galactomannan monitoring twice weekly. These are the values: greater than 0.5. CT scan, lung lesion consistent with invasive. Then you should go for a bronchoscopy. Okay, so this is a diagnostic approach. So coming to chronic, so it affects patients with underlying lung disease, no or mild immunosuppression, presence of a fungal ball is a hallmark. So other features like if you have a previous CT scan, expansion or wall thickening of the pre-existing cavity, parenchymal destruction, fibrosis around the pre-existing cavity, pleural thickening or effusion, enlargement or pseudoaneurysm of a bronchial artery, these are suspicion for your chronic pulmonary aspergillosis. So aspergillus nodules are there also very hallmark of this. They are often misdiagnosed as a CLM. So that was, we have to have a suspicion in our mind to look for aspergillus if there is a nodule. Send respiratory samples for testing. Aspergillus PCR is very sensitive, although very poor, not very specific. Specificity is of around 70%. Then galactomannan of BAL can be sent. Serum galactomannan has very poor sensitivity. So coming to treatment for chronic, so polyenes like deoxycholate, amphotericin B, liposomal amphotericin B, these all can be given. These are the doses. Triazoles can also be given. Urazoles, itraconazole, voriconazole, posaconazole, isavuconazole. So voriconazole is our first choice for treatment of invasive pulmonary aspergillosis. Okay. So intravenous 6 mg per kg twice daily, then 4 mg per kg twice daily. And if there is a AKI, as I told you in voriconazole, it also has cyclodextrin as a carrier molecule. You may shift to your oral voriconazole after first day of intravenous voriconazole. Oral voriconazole has 100% viability, so that is why oral voriconazole is also very effective. Unless the patient is in severe shock, so there will be minimal absorption from the intestines. So you may, in those cases, in severe shock patients, you may have to go for IV. So echinocandins, again caspofungin, andulafungin, micafungin, these are the doses. So therapeutic drug monitoring is recommended for itraconazole, voriconazole, and posaconazole. Voriconazole trough concentration of 1 to 5.5 milligram per liter. Your invasive pulmonary aspergillosis due to azole resistant fumigatus, they have higher mortality. If there is azole resistant, they have very high mortality rates compared to azole susceptible aspirates. So there are some newer drugs, olorofim and fosmanogepix. This is a pro drug that gets converted to manogepix. So invasive pulmonary aspergillosis initiated promptly whenever you suspect an invasive pulmonary aspergillosis. Remind it that therapy should be started only after bronchoscopy. Otherwise, it may hamper our chances of detection. So triazoles, they have for only for proven or probable IPA. Then liposomal amphotericin B is only for possible IPA to ensure broad coverage, including mucorals. Combination therapies can be given in severe or refractory invasive pulmonary aspergillosis. Surgery only rare, only if source control is widespread, like in pulmonary aspergillosis, invasive pulmonary aspergillosis, it has spread to mediastinum or to the cardiac. Only then surgery is needed. Otherwise, it is very rarely needed in case of aspergillosis, although it is mainstay of treatment in mucormycosis. So bone marrow recovery or reduction of immunosuppression are important outcome determinants. So we have to you could remove the immunosuppression causes like diabetes and all. We have to take care of that first. But the faster the control, the better. The duration of treatment is at least 6 to 12 weeks, depending on the recovery of immunosuppression and evaluation of CT lesions. So we have to do serial CT scans every 4 to 6 weeks to see if there is resolution of the aspergillosis. So chronic multidisciplinary approach involving pulmonologist, thoracic surgeons, radiologists, infectious disease specialists. Indications for surgery depends on individual to individual, size of the lesions, and if any underlying structural lung disease, the degree of lung impairment depends on that surgery is needed or not. So preoperative antifungal therapy may be warranted to prevent spillage of the fungus, and if there is partial resection, post-operative antifungal therapy should also be given. Long-term suppressive antifungal therapy is usually required in these patients. Regular chest CT, in this case chronic, we have to do every 3 to 6 months to assess the response. Itraconazole may be used as a first-line therapy because of its low cost and very good safety profile, although QT prolongation and all risks are present. So voriconazole is for very severe diseases. Echinocandin therapy may be considered in case of intolerance or resistance to azoles. So newer drugs, rizofengin, ibrexafungerp, so novel oral beta-glucan synthase inhibitor, although limited data of use of these drugs. So failure of therapy and surgery not possible in case of your chronic pulmonary aspergillosis. Direct installation of amphotericin B or triazoles in the cavity has shown some efficacy, although again not proven. Thank you. Any doubts, please write in the comment box.
That's very good presentation, sir. Without any delay, I want to welcome the next speaker, Dr. Shakti Mishra, HOD of Critical Care Medicine, IMS in some hospital, to speak on how to critically evaluate a scientific paper. Samir sir, kindly unshare your screen. Shakti sir, please share his screen.
The slides are visible.
Yes, sir, the slides are visible. Please proceed, sir.
Yeah. Good evening, everyone. My topic is going to be very small. It's regarding how to read a scientific paper. So before I go into the topic, there are two ways when we read a paper. One can be as a clinician, when I'm dealing with a clinical question and I am searching the paper for what is my clinical answer for management of a particular patient, or I'm trying to do some research. So for a clinician, it may not be so to do a more extensive study of the papers. Just understanding what the population and the intervention was may be sufficient. But most of the things that I'm going to say is going to apply for a researcher who is going to read a paper. So a lot of literature are coming out. This is just the RCTs which have been done in critical care in the last week, which have been published in the last week. So when you're actually doing a literature search and you're trying to search what study you have to going to read, first you need to select a paper. So to select a paper, you need to first check the title. That is the first thing that you should check. So while you're checking the title, make sure that it is relevant to you, that the topic is relevant to you, it is related with your subject, related with the population that you are dealing with, and it is related with the intervention is of interest to you. The next is note the key terms and try to see if the research question that they're looking for is essential or relevant to you. Now, next is try to find the authors and affiliations. Just 1 minute. Sorry for the interruption. Yeah. So next you try to find where the study is coming from, because say, for example, you are trying to find the ventilator associated pneumonia rates for India. You don't need to look for studies which have been published in the US or Europe. So looking at the affiliation and the authors who have done this is also relevant. The next thing that you look for is note the date and the year of publication. This is also relevant because what you want to search may be recent or it may be something old. So what date the research has been published is also relevant. So once you have done all this, you will select a paper which you will like to study. So say, for example, this is the paper that I'm going to cite. This is a paper which I felt that I should be reading. This is intensive versus conventional glucose control in critically ill patients. This is the NICE sugar trial published in NEJM 2009. Now, the one thing that you should never do is do not read the title and the conclusion. That is not how you go about reading a scientific paper. So how to do it, I will tell. The first thing that you must do is read the abstract. Abstract is being written for that purpose only, so that it gives you a brief overview of what is going to be inside the scientific paper. So while you are reading the abstract, try to follow this algorithm or the mnemonic, that is PICO. P for population or problem, I for intervention, C for comparison, O for outcome. Patient or population or the problem describes the patient or the population that is the focus of the study. The factors that can be important here is the age, gender, health status, or relevant demographic information that has been given. Like for in this case, we are looking at critically ill patients. So that is the population which has been cited. The next is the intervention. What has been done and which particular treatment is being investigated here. It can be anything. It can be a drug, a procedure, a diagnostic test, or any other healthcare measure. So here what we were looking for is the intensive treatment of blood sugar control. The next is comparison. You must have a comparator group. It can be a placebo group, a standard care group, and as in this case, it is a control group where you are measuring the conventional glucose control norms. Finally, you are looking at something. You have to have some outcome based on the problem and the intervention I've done. I'm looking at some clinically relevant outcome or something else as my outcome. So this 4 things must be looked at when I'm trying to read the abstract. So as this is the abstract of that study, I'll be focusing mainly on the background and the methods when I'm reading the abstract to finalize whether I should continue reading this paper further or not. As you can see here, it describes the population, the intervention that has been done, and the primary outcome, that is the death. So after reading all this, in my mind, I am now making clear whether I should continue reading this paper further or not. Most of the time, you will be able to be clear that whether I should read the main paper or I should just stop with this. So this is the first initial steps. So once you have decided, either I am reading the paper more details or I'm just stopping over here. If I'm reading the paper in more details, then what will I do is next I will go into the introduction, where I need to understand the background information that is there. Where the studies which have been done before, why this particular problem is still considered relevant by the authors, and why there is a problem which they are trying to address. Once we have known what is the background and what is the problem, next we will try to find what is the hypothesis. What are we trying to find out in this particular study? So this is the 3 information which you should get when you're reading the introduction: the background information, the problem statement, and the hypothesis. Next, you go into the method section where you try to see what is the study design. Whether it's a RCT, whether it is a case control or an observational study, what type of study design has been done. Next is who are the participants. We have known the population before, but is there any further description? Who are included, who are excluded, and what exactly is the population who will be getting the intervention? Next, you have to know exactly what the intervention are, how it is being provided, and what treatments are being given in the control group. And apart from the intervention per se, what other things are being done in the standard management. Next is blinding. Is the intervention blinded or not? And the data collection methods. What methods are being used to collect the relevant clinical outcomes? Who is collecting the data? How is the data being collected? Say, for example, I'm looking at outcome after a neurological intervention. So I'm looking at some kind of a scoring at 6 months. So different outcomes can have different scorings, or there can be something specific like a mortality rate or days on ventilator or length of stay or something like that. Or it can be a score which has been attributed to, say, for example, the quality of life of that patient. Next, you read the statistical methods. Once you have read the methods per se, how was the sample size calculated? What are the tests they are going to employ? What assumptions are they taking in their tests? And whether the people who are doing the calculation or the statistical analysis, are they blinded to the groups or not? Next, in the results section, you will read how the data is presented, in tables and graphs. You analyze this, look at the statistical analysis, what has been done, what tests which were told in this previous section, have they been applied and how they have been applied? What are you finding? The figures and the tables. Next is the discussion and conclusion. Here you try to interpret these results based on the previous evidence. How are these recent findings correlating with the previous findings that we have? Say, for example, how is this intensive control comparing itself with the previous data that was there before this study was published? Next is implication for the field. How is this result affecting my clinical practice or future research? How it will affect my future plans? Next is every study will have some limitations. So you need to study those limitations, because if you are planning a future study, then you need to overcome these limitations. Only then it is going to be of some importance. Then there are some additional sections once you have gone through all this. That is, you need to know who is funding the study. Say, for example, if a particular catheter is being promoted and the catheter company is the one who is funding, so there is always a conflict of interest. So you need to know what are the conflict of interests and from where the source of funding is coming from to do this study. The references are important because you need to cross-check the future research, the previous research that was done, and also the previous animal or physiological studies which have been done for this study to be done right now. Then you have supplementary materials where you will find additional results or additional informations about the methodology, or additional results like more tables or graphs could be presented in the supplementary material. So once you have gone through all this study, there are 4 questions you need to ask yourself to evaluate a trial. So these are, the first one is, what was the effect size utilized to check the sample size? Is the effect size too large? If the effect size which has been assumed is too large, then it will give me a less sample size, but it will dilute the power of my study. So in this particular study, in the context of the insulin therapy that we were nice sugar trial, they originally designed to enroll 4,000 patients. But later on, with the data being presented of the Vandenberg trial, that is 2006 intensive insulin therapy trial, they increased the sample size to 6,100, thereby increasing the power of their study to 90%. Here, the effect size that we need to focus on is the 3.8 percentage point, which means that they assumed a mortality of 30% and a 3.8% reduction, that is 26.2% expected mortality in the intervention group where we are giving intensive insulin control. So if this particular percentage point is taken to be very large, then the sample size that I will need will be much less than 6,100. But then this must be clinically relevant. The sample size which I am expecting must have some clinical basis and relevance before I am assuming this. If I assume a very large percentage point decrease without any relevant evidence, I'm just using that to reduce my sample size. And later on, it will affect the power of my study. The next is the trial really being given in those patients who are susceptible to the intervention? Take, for example, this particular study. This was the high versus low PEEP in patients with ARDS. This is a famous ARTSNet trial of 2004 in NEJM. If you look at their inclusion criteria, they included patients who were fulfilling the criteria for ARDS according to the definition back then, which was a PF ratio of less than 300 or less. So the problem here is we are including any patient who is having a PF of 300 or less. So a patient who has a mild ARDS, say for example, a PF ratio between 200 to 300, is unlikely to show any benefit of giving a higher PEEP. So if I am including those patients in this particular study, I am only diluting the result that I'm going to get, because these patients were never at all a patient group who were to give any benefit from high PEEP. So this is a very important aspect. Is the intervention actually being given to susceptible patients? So until and unless I get that susceptible group or the subphenotype, I will always get negative results. Similar thing, this is the LOVID trial. This is checked for IV vitamin C for sepsis in ICU patients. And their criteria was eligible patients, that is adults, who were admitted to the ICU for no longer than 24 hours, who had a proven or suspected, that is they were having some kind of a sepsis, and who were receiving vasopressors. Now, the point to be noted here is the dose of the vasopressor is not written, which means that any dose of vasopressor must be getting this particular therapy. So again, a patient with a very low dose vasopressor, say for example, just getting 1 ampule NORAD at 2 to 3 ml per hour, is not necessarily requiring a vitamin C to overcome the problems. So if that particular population is included, again, I will unlikely find any positive result in this trial. So next is the third question. Whenever I'm doing an intervention, I want a meaningful separation between the two groups. Is the separation sufficient enough clinically? Because just having a graph, I can make this graph a separation of 1 point or 2 point and make the graph show that there is a huge difference, but it may not be clinically significant. So it has to be a clinically meaningful separation between the two groups that I'm analyzing. So I'm taking the example that I've already taken, that is the glucose control. Here you can see the glucose control in the conventional group is around 140, while that in the intensive glucose control group is around 108 or 110 rather. So is this 30 milligram per deciliter difference that I am seeing clinically relevant? Am I really going to see clinical benefits just by getting 30 milligram per deciliter difference between the two groups? Maybe the conventional glucose control outside a research setting is not this good. You can see that there is a very good glucose control in the conventional group. This may not be the scenario in all patients. So these things have to be kept in mind. What was the separation between the two groups, and is this difference clinically relevant? I will give another example. Say, for example, I'm comparing balanced salt solution with normal saline. So what I must get is a clinically meaningful difference in the chloride levels. So there has to be a clinically significant difference between the chloride levels in the two population. Otherwise, there is no point of doing this study. Many of the studies have never quoted their chloride levels also. And even if they're quoted, there has to be a significant difference, clinically significant difference. Just 120 versus 110 may not be a clinically significant difference for the two groups to show difference. If the two groups are so similar, the result is expected to be similar, which is no difference between the two groups. And finally, once you have a difference, that difference must make some sense based on the prior knowledge or with biological plausibility. We can't just make a study and give a result without any biological plausibility. For example, if you go into the NICE sugar trial, they showed a clinically significant mortality difference between the glucose, conventional glucose, and the intensive glucose control group, which means that 30 milligram per deciliter difference that you saw in the previous graph was so significant, it resulted in death of the patient in the intensive control group. Now, it must have some basis. What is the knowledge basis and what is the biological explanation for that kind of a finding? Now, they do show that the severe hypoglycemia was 272 episodes in the intensive control group, while only 16 in the conventional control group. Now, they do claim that this severe hypoglycemia did not have any impact on the long-term outcomes. However, so then how are we explaining this harm? This harm that we are seeing in the intensive control group has to be because of the reduced blood sugar. If I'm keeping a blood sugar of 110, it is somehow killing the patients. Or insulin is killing the patients because more insulin was given. Or as we have seen, the occurrence of hypoglycemia probably resulted in deaths. Or there was some methodological factor which was specific to this particular trial, which we are not aware yet how it is affecting the patient and resulting in this outcome. And lastly, there is some other factor which we are not sure of. So any result when we get positive, it must have some biological basis. I will just give one more example, the similar example, that is the LOVIT trial. They showed a decreased survival with vitamin C. Now the point is, why should the patient die with vitamin C? Is there any biologically explainable reason for why the patient patient who is receiving vitamin C will die? So we need, if at all we are finding something, then we must do further research to find out what are the possible reasons of this type of an outcome. So once when you select your study and paper that you are going to study and you follow these methods, most likely you will be able to get a brief idea about what they are trying to show, and it may impact your clinical practice. Thank you for your patience. That's all for today.
That's very, very nice presentation, sir. Without any delay, I want to welcome Dr. Rohit Patnaik, sir, Associate Professor, Department of Critical Care Medicine, IMS and some hospital, to talk about case presentation on a patient with sepsis and septic shock. Sir, Rohit, sir, off to you, sir. Please share your screen.
Is my screen visible?
Yes, sir, it's visible. Please proceed, sir.
And I'm audible and visible.
Yeah, you're audible. You can proceed.
Okay. Thank you, everyone. So basically, this topic is on approach to case of septic shock. So what I will be touching on is the practical aspects that you will have to speak when you do your case presentation in a patient with septic shock. The etiology of sepsis and on the septic shock might be anything. So in that case, you will have to focus on that particular etiology also a little bit. But in your practical case, these are the things that they will ask you in your practical exam when you approach a case of septic shock. So this is probably a case that you might face in your examination, where this is a 63-year-old male patient, which has come up to known diabetic and chronic alcoholic. So basically, this patient was brought to the casualty by the relatives with complaints of fever, altered sensorium, and loose stools of 3 days duration. And on examination, patient was very drowsy, tachycardic, very thready pulse, hypotensive, tachypneic, all of these features. And once we examined the abdomen, it was distended and tense. So remember, whatever is the site or source of sepsis that you think, you have to focus on examination on that particular site or source as well. So standing chest X-ray shows gas under the diaphragm. So this looks like an abdominal sepsis. And the CT scan showed a gas under diaphragm and free fluid, which was suggestive of peritonitis. And the ABG was actually showing a bit of metabolic acidosis. And if you see here, PO2s was 67 with FiO2 of 0.4. So there was a bit of hypoxemia as well, PF ratio around 150. And electrolytes were sodium 126, chloride 88, sugars were okay at 168. So based on this case, we can see that this patient was having all the features of sepsis. And this brings us to the first question that examiners might ask you as to what is the diagnosis after you see this case. So you have to say that this is a case of perforation peritonitis in septic shock or with septic shock with severe metabolic acidosis. This is what is your diagnosis that is going to be. And then they might ask you questions about what is sepsis. So sepsis definition, you have to keep it in your mind. You have to keep it, you have to be completely by heart. Dr. Viswajit has touched on it in his first class of today. But just to remember, these are the 3 points you have to tell, that it is a life-threatening organ dysfunction caused by dysregulated host response to infection. This is the key word. That is the dysregulated word is the key word which you have to remember, that it is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And what is septic shock? Remember, it is just a subset of sepsis where there is an underlying circulatory and cellular or metabolic abnormality, which is extremely profound enough to cause an increase in the mortality. So if you see, sepsis in itself has a mortality of around 10% to 15%. But once it goes to septic shock, your mortality increases up to 40%. And then how is it defined in terms of your pressures? So if you see, if there is persistent hypotension requiring a vasopressor support to maintain a MAP of more than 65 after adequate fluid resuscitation, this is what is the definition of septic shock. And serum lactates also have to be more than 2 millimoles per liter. So this is a subset of sepsis which has got increased mortality. So definitely these are the group of patients that we have to be extremely careful when we are going to treat them. So how to resuscitate this patient? And resuscitation of this patient of septic shock is from our sepsis guidelines. The most recent one is in 2021. So the 2019 update of the 2016 guidelines actually mentioned the presence of this sepsis bundle, and this was revised, and a 3-hour and 6-hour bundle was eliminated. And in 2019 update of the 2016 guidelines, we got a 1-hour bundle. The 2021 guidelines don't mention us about any specific bundles, but they tell us to perform as early as possible the components of the bundle that you are going to perform. So there is no particular timeline that is mentioned in the 2021 guidelines, but these are the things that you have to do to resuscitate the patient of septic shock. First and foremost, you have to do an ABG and measure the lactate level, and remeasure if the initial lactate is more than 2. You give some therapy and you remeasure your lactate values after your therapy. Obtain blood cultures prior to administration of antibiotics. Obviously, this is most important. You need to give in your antibiotics as early as possible, but do not delay blood cultures. Do not delay your antibiotics because you are going to take blood cultures. If it's taking time to take cultures, you give your antibiotics as early as possible. Administer broad spectrum antibiotics. Begin administration of a 30 ml per kg crystalloid for hypotension, or if your lactate is more than 4. So remember, this 30 ml per kg is not based on very sound evidence. So the initial resuscitation is always based on your feedback that you keep getting after the evaluation of your patient after giving an initial fluid bolus. So you can give a 10 ml per kg fluid bolus and then evaluate this patient whether he needs further fluid boluses based on the peripheral perfusion that this patient has got. And if you see here, the lactate is one of the peripheral perfusion markers, but I'll come to the other peripheral perfusion markers in my next slide. So just in case your initial fluid bolus is reached up to 30 ml per kg and still the patient was hypotensive, then you probably can start vasopressors. But the concept nowadays is moving towards the fact that before you finish your 30 ml per kg, you can start vasopressors hand in hand. So that's why here it is written that your vasopressors you started if your patient is hypotensive during the resuscitation or even after the resuscitation. So even during the resuscitation, you can start your vasopressors and you maintain a MAP of more than equal to 65. So this is one of the main questions that is going to be asked to you as to how you are going to proceed to resuscitate this patient. And what MAP targets are you going to target? As mentioned here, it is going to be at least 65. In patients who are chronically hypertensive, they might need a higher MAP. Although there has been no mortality benefit with respect to keeping a higher MAP in chronic hypertensive patients, but definitely the need of renal replacement therapy has been lower in patients with common hypertension, and you keep a slightly higher MAP target for such sort of patients. So this is the overall initial questions that you might ask as to what the patient got resuscitated with, what the ED gave the resuscitation, how much resuscitation was given, how much fluid, what vasopressors were given. All this information you need to collect when you present cases for your practical examination. You might also be cast on peripheral perfusion assessment. This is one of the main questions that we will ask you. How to clinically assess for peripheral perfusion assessment and how to see for temperature gradients. So if you see clinical assessment, it can be done in 3 ways. One is just to touch the patient and touch the extremities and see whether it is cold or warm. And the main advantage of this is easily performed and it can be done based only on your clinical examination just by touching the patient. But the limitation is some of it is quite a bit of operator dependencies present because some patients might, somebody might say it is neutral, not cold or not warm, but to somebody else, it might feel as if it is cold. That is the only way. But it's a very, very easy way to know whether your patient has got good peripheral perfusion. Patients in the early phase of sepsis will have warm extremities or in the early phase of septic shock. But as the shock worsens further and your disease process worsens further, patients will start developing cold peripheries. So accordingly, you can also have differences in the body temperature gradient, whether it is from the central to the peripheral. So as you move from your periphery towards the center, your gradient increases. That is, the peripheries might be cold and the center might be warmer. So based on that, you will have the difference. So the difference is too much or higher, then you have a patient who is at the much worse end of the spectrum in terms of his peripheral perfusion. So that is how you come to know about body temperature gradient. So palpate your periphery from your toes to your ankles to your knees and then above up till your hips. So all of that you can see. Similarly in the hand as well, you can move from periphery to the center and just see for the gradient in general. But actually, as per the studies which have been done, you ideally have to measure it with a temperature probe, with a skin temperature probe and see how much is the difference. So usually they say that the cutoff is if more than 4 degrees centigrade, then there's a high chance of morbidity and mortality. So usually this reflects very poor perfusion. What are the other clinical assessment that you can do? The other clinical assessment is seen for capillary refill time. So what is capillary refill time? Basically, you put your finger on your nail bed and press your nail bed for more than 5 seconds. And once you press it, you leave it after pressing it for 5 seconds. And if you see that your that your nail bed has blanched, and then once your blanching has happened, once you leave your pressure on the finger, the blanching should go. But if your blanching doesn't go within a period of 4 to 5 seconds, here it is 4.5 seconds that is mentioned, within 4 to 5 seconds, then you know that your patient has got poor peripheral perfusion. So this has been actually tested in the Andromeda shock trial, where they tested for whether the lactate performs better or whether the capillary refill time has performed better with respect to peripheral perfusion assessment. What about mottling score? Patients in the severe and fag end of sepsis will start developing mottling. Septic shock will start presenting as mottling. And this is a widely described sign. And I will come to it in the next slide as to see the scoring, how you score the mottling. So score of 4 to 5 is extremely poor scoring, and you will have high mortality and very poor peripheral perfusion if your score is around 4 to 5. Some of the newer methods are also there to assess for peripheral perfusion, like the peripheral perfusion index. Okay, and the other thing is near infrared spectroscopy. I will not touch on all of this because all hospitals might not be having this instruments for your peripheral perfusion assessment. But definitely your clinical assessment, including all these three, as well as your periphery to core temperature gradient, is one of the most important things that you have to speak when you tell about peripheral perfusion assessment when your examiners ask you in your practical exam. So what about mottling? I told you mottling is one thing which happens when your septic shock has progressed a lot. And then when this mottling happens, it is graded as either 0, 1, 2, 3, 4, 5. So if you see here, the score here is 0, presents no mottling. Score 1 is when there is a small mottling area here, which is point sized around the knee. And when there is a little bit of more amount of mottling, which increases around the knee, but it does not go beyond the superior edge of the kneecap. Okay, this is the kneecap here. For beyond the superior edge of the kneecap, if it doesn't go, then it's grade 2 or score 2. And once it goes to score 3, it increases further, but it does not exceed the middle of the thigh. Okay. And what is grade 4? 4 represents the mottling area even more further, but it doesn't go beyond the fold of the groin. Okay, so this is the groin fold. So beyond it doesn't go, but score 5 is something which goes beyond the groin. So this is one scoring system which you have to remember. This is one of the favorite questions that examiners keep asking you about mottling scoring. So what about biomarkers? Once you've given your antibiotics, fluids, all of that, you want to know how bad is the sepsis. So biomarkers will help you in that. Procalcitonin is the most widely used biomarker, and usually it is not at all detectable, and normal levels are seen in healthy individuals. But whether procalcitonin helps you to diagnose sepsis? No, it doesn't help you in diagnosis of sepsis. What it actually helps you, and studies have shown, is the only place where procalcitonin has been shown to benefit with the pro-rata trial as well, is that there is discontinuation of antibiotic therapy, which is encouraged if there is levels below 80% of the initial value. That is the only place. That is, de-escalation of therapy is the only place where procalcitonin has found to be beneficial. It is not for your diagnosis of sepsis. So suppose somebody did send the procalcitonin at presentation, that cannot be used to know for the severity of sepsis or for the diagnosis of sepsis. The only thing that can be used for is further values after the initial value at presentation will help you to guide your de-escalation of antibiotic therapy. So that is the only place which will help you, procalcitonin. So once we move forward, our patient was basically with this amount of hypoxia and acidosis. Patient was intubated and a tidal volume of 6 ml per kg of ideal body weight was started. A MAP was 56 in spite of fluid boluses, and the initial procalcitonin value was very high at 152 nanogram per ml. And a surgical consultation was made, emergency laparotomy planned, and emergency laparotomy done, revealed a perforated sigmoid mass with gross fecal contamination and peritonitis. And once even the adequate fluid resuscitation was done, vasopressors were started. We did see that septic shock was when adequate fluid resuscitation boluses were given, and then still your vasopressors were needed to maintain a MAP of more than 65. So patients still continued to be oliguric, renal replacement therapy was started, and the cultures which was sent revealed E. coli growth. And 3 sessions of RRT were done, urine output and oxygenation improved, and then we were planning for weaning for this patient. So this is how you will manage a patient of sepsis and septic shock, but you have to remember the points and questions which you have to tell during a case presentation and the questions which will be asked. So moving further, if you see, so how, when, and which vasopressor to use? This is one of the main things that they always keep asking you. catecholamines are important in septic shock, and noradrenaline remains to be your first choice vasopressor. Remember, you have to remember a few trials where dopamine was found to increase mortality. Okay, so that you have to remember, read up on that. Noradrenaline has been better than dopamine, and vasopressin is always the second line agent in case of septic shock. Okay, so these are the two vasopressors that you have to remember when you tell about vasopressor usage in a patient with septic shock. And always remember, when you present cases, mention your vasopressor dose, that is the noradrenaline dose, in mics per kg per minute. Okay, and not an ml per hour of infusion that the patient would be getting. You have to convert it to mics per kg per minute and tell the dose of your noradrenaline. Similarly, your vasopressin, you have to tell in terms of mics per minute and not tell the ml per minute which is going on. So you have to tell in terms of mics per minute. Okay. So what about the role of steroids? Definitely role of steroids is there. Adrenal trial has shown us no mortality benefit, but definitely adrenal trial has shown us that it reduces the amount of duration of ventilator support, duration of need of mechanical ventilation, and amount of stay in the ICU. So even though steroids are being used left, right, and center, remember it does not have mortality benefit, but definitely it has some amount of morbidity benefit in terms of reduced duration of ICU stay as well as reduced duration of mechanical ventilation. Guidelines recommend 200 mg per day of hydrocot for vasopressor use for vasopressor refractory shock. And basically, the internal trial investigators also tell you that even before your shock actually has developed and you know that the patient is going towards septic shock, you can actually start hydrocortisone. There is no particular dose of the vasopressor when you have to start using hydrocortisone. Hydrocortisone can be given in 50 mg 4 bolus doses per day, or it can also be given as an infusion dose for 24 hours. So this is the role of steroids that they will keep asking you every time during a septic shock presentation. What about source control? Source control, never forget that in the midst of all the antibiotics, fluids, vasopressors, and steroids and all of that, we always forget that we have to push it for a source control. If your source is not evident and it is diffuse, in case of suppose a pneumonia, without any abscess, without any empyema, then you just have to tell that there is no particular source control that can be done. But if there is a source, you always keep going back to that and keep telling that your source control is your most important thing. What about soda bicarbonate? Soda bicarbonate has no role in case of a patient who has got acidosis, metabolic acidosis. The only place where soda bicarbonate has got a role is when your patient's pH is more less than 7.1, and the risks of having such severe metabolic acidosis is much outweighs the benefits, and the risks are much higher than the benefits. So that is where you will have the use of soda bicarbonate just to tide and get a certain amount of time period before you proceed for a renal replacement therapy. Why is it so? Because soda bicarbonate has a lot of extracellular acidemia, which can eventually worsen your intracellular acidosis by the production of carbon dioxide. We usually see a transient improvement, but remember that if your septic shock worsens further, this soda bicarbonate can contribute to the metabolic acidosis even further. Secondly, fluid overload is also one of the things. It is a very hyperosmolar solution. So definitely fluid overload can happen. Ionized hypocalcemia can happen, leading to arrhythmias. These are all the risks of soda bicarbonate. Okay. So what about further fluid therapy? We did give a certain amount of fluids. We started some vasopressors, and then our patient is in our ICU. And suppose patients develop a certain amount of hypotension again after your initial resuscitation and stabilization. So at this point of time, what you need to do is, before going blindly for fluids, you have to start doing your fluid responsiveness, because the harms of fluid are going to be very high after your initial resuscitation. So you don't want to harm your patient, and that's why you want to do a test of fluid responsiveness. So what is fluid responsiveness? It basically refers to the ability of the heart to increase stroke volume or cardiac output in response to a fluid bolus. So the only reason that you're going to give fluids after your initial resuscitation is if your cardiac output is going to increase. And to know whether it is going to increase, you have to do a test of fluid responsiveness. And this fluid responsiveness means that both the ventricles, that is both the RV as well as the LV, are fluid responsive. Even if one of the ventricles is not fluid responsive, you will have a negative fluid responsiveness test. So remember, if your test is positive, that is the only time that you're going to think of giving fluids. So this brings us to the Flank-Stanley relationship. If you see here on the x-axis is the cardiac preload, on the y-axis is the stroke volume. So by giving or doing a test of fluid responsiveness, that is by giving a preload challenge. Remember, preload challenge is different from having a particular amount of cardiac preload. Preload challenge is basically a change in the cardiac preload and not a particular cardiac preload. A central venous pressure gives you a particular cardiac preload, that is a particular single value. But what you want to do with your test of fluid responsiveness by either using the mechanical ventilation or your end expiratory occlusion, ALR test, or a mini fluid challenge is to produce a change in the cardiac preload and to see whether that particular change in the cardiac preload is producing a significant increase in the stroke volume. That is, an increase in the preload producing an increase in the stroke volume. So that happens where, if you see here, this is a family of Fram-Starling curves. If you see here in a patient with normal ventricular systolic function, in this part of the steep part of the curve, that is where you will have an increase or a significant response. But in a patient with poor ventricular function, in this same part, you will have a no response. So one is when your patient is on the steep part. Second is compared to the patient who is on this flat part. And the second is if your patient has got a poor ventricular function. And this is the two places that you have to remember that your patients will have a positive fluid challenge. So if your patient has a good heart and working on your steep part of your Frank-Starling relationship, this is where you have a significant response. And what is significant? Increase in the preload will produce an increase in the stroke volume. And that is the only reason why you want to give your fluids once your initial resuscitation is over. So just to elaborate a little further, what are the various tests or what are the various methods by which you can increase the cardiac preload to check for an increase in the stroke volume? So these are the various methods: the passive leg raising test, a mini fluid challenge. You can see for mechanical ventilation induced changes in the pulse pressure variation on the arterial line. You can see for the vena cava collapsibility, end expiratory occlusion test. You can do a tidal volume challenge, or you can also do a psi maneuver. So all of these are the tests which see for an increase in the cardiac preload and whether that is increasing the stroke volume adequately. And I will come to the cutoffs in later few slides. Don't need to focus here on the cutoffs. So what is pulse pressure variation and stroke volume variation? If you see here, every patient can have a positive pulse pressure variation. But in patients who are fluid responsive, patients they will have a increased amounts of pulse pressure variation. And pulse pressure variation increased amounts, what I mean by that is basically having pulse pressure variation which is high, which is defined as more than 12%. So if you have a patient on the steep part of a Frank-Starling curve who is preload responsive, if you have that patient and have an arterial line on this patient, you can see for the pulse pressure variation. If it is more than 12%, patient is preload responsive. Okay. And if it is less than 12%, patient is not preload responsive. So if your patient is preload responsive, you can safely give fluids. Patient will have increase in the cardiac output and patient will have increase in the peripheral perfusion. So what about the various pitfalls of using the pulse pressure variation or stroke volume variation? Patients who are having spontaneous breathing, you can have false positive pulse pressure variation and false positive increase in the pulse pressure variation. What about cardiac arrhythmias? Patients might have falsely positive, falsely increased pulse pressure variation if you have cardiac arrhythmias. Low tidal volume ventilation, less than 8 ml per kg, is something, again, can have false negative. Patients who are actually fluid responsive might be showing up as fluid unresponsive because of the PPV values. What about low compliance? In ARDS patients, we have very low compliance. So this is one of the pitfalls of using pulse pressure variation in patients with low compliance. They can have falsely negative values. That is, your pulse pressure variation should be more than 12%, but it will be less than 12%, and you will think that the patient is fluid unresponsive. So these are the various pitfalls which are there with PPV and SVV. So what about variations in IVC diameter? You can see for that as well. This is a very common thing that I see in a lot of patients. A lot of residents keep doing variations in IVC diameter. But remember, variations in IVC diameter is something you have to do only in mechanically positively ventilated patients, positive pressure ventilation. And also with that, the extremes of values are the ones where you have seen that there is some benefit. But remember, in spontaneously breathing patients who are not intubated, even on an intubated patient who is taking spontaneous breaths, variations in IVC diameters are not very reliable. So what do? You put a probe, ultrasound probe, in the subcostal area and check for the IVC. Once you put an M mode on that IVC, you will get a changes in the IVC diameter. And this is the IVC min diameter, IVC max diameter on M mode. And these are the formulas There are two formulas to it. If you use this formula, that is more than 12% is the cutoff to define that the patient is fluid responsive. And if it is more than 18% in this formula, then the patient can be defined as being fluid responsive. What about the fact that if you have a high IVC distensibility index, then you have a high PPV as well in that patient, and that is also again at more than 12% is what is the cutoff for your high IVC distensibility index and patient calling the patient as fluid responsive. What about passive leg raising test? This is one of a very common tests which we can do in our ICU. Very easy to do. You just keep the patient in this 30-degree head up position, 45-degree head up position. Once you take this patient down with his head end down and his leg end up, with whole bed being transferred and not individually the particular sets of the head and the foot end being changed. Once you do that, you have a mobilization of around 300 ml of fluid into the patient's heart. And once you have a mobilization of self-fluid challenge, which we call it, you will have an increase in the cardiac output if the patient is fluid responsive. So what are the various things that we see? Similarly, as I said, the fundamental physiology is you give a challenge of cardiac preload, increase the preload. In a PLR test, you give a self-fluid challenge, and what you are seeing for is whether your stroke volume is increasing. If it is significant increase, patient is fluid responsive. If it is not no significant increase here as it is shown, then the patient is not fluid responsive. So a cutoff around 10%. That is, if you do a PLR test and you see for a increase in the stroke volume or cardiac output of more than 10%, then you can call the patient as fluid responsive. If it is less than 10%, patient is not fluid responsive. So if you see further, this is how to do a PLR test. You do first a PLR test in, you have a patient who is at baseline 1 in this position. All our patients in ICU are in this position. You do a PLR test here, see for the response, and again bring back the patient to your baseline. So this baseline 1 is same as baseline 2. The only thing you have to ensure is your baseline parameters, which you have seen in your PLR test in terms of either your PPV, in terms of your cardiac output, anything, that should come back to your baseline in the baseline 2 as well. So that is one thing, or else your PLR test is not validated. Okay. So this is one of the things you have to do. Once you do the PLR test, how to see for the response in terms of your stroke volume? They're very easy to see. You have to do a 5-chamber view, apical 5-chamber view, and see for the LVOT VTI. And once you see the LVOT VTI, you can easily calculate your stroke volume from the LVOT VTI. So this is how you see your velocities, all of your, even your max velocities, you can see how much of your max velocity you have. And accordingly also there are some few cutoffs to that. So what are the advantages of a PLR test? It is reversible. It does not depend on ventilation and heart rate. Remember, so like your PPV in low tidal volume and in arrhythmias, it is not dependable, but PLR test is very dependable in case of all these cases. And third, it is reliable with even spontaneous ventilation as well as cardiac arrhythmias as well. So in all the places where the PPV was not beneficial, the PLR test is beneficial, and there have been several studies which have validated the PLR test. So just to summarize the dynamic markers of fluid responsiveness, and these are the various thresholds which are there. If you see here, pulse pressure or stroke volume variation threshold is 12%, inferior vena cava diameter 12%, PLR test 10%, end expiratory occlusion test 5%, a mini fluid challenge of giving 100 ml is at 6%, and a conventional fluid challenge is of 15%. So suppose you give a 500 ml fluid bolus, this is the 15% that you're looking for to tell that this patient is fluid responsive now. So what about NDR, PDR next year? Usually once your fluid part of discussion and fluid questions are over, definitely examiners will try to come on to the antibiotic part. So you need to know your antibiotic, whether your antibiotic choices, what are your antibiotic choices. I won't be dealing much into that, but definitely one of the questions that they keep asking you is whether this patient has got an MDR bug during his hospital stay. So what is MDR? What is XDR? What is PDR? If you see here, this is basically a subset of each of it. So if there is no MDR, this is the bigger subset. Within that, there is MDR. Within that, it is there is presence of the XDR, and within that is the PDR. So what is MDR? MDR is basically some bug which is not susceptible to at least one agent in 3 or more antimicrobial categories. Okay, so remember, it has to be at least one agent, but the number of categories has to be at least 3. So suppose a bug is resistant to ceftriaxone, bactrin, and ciprofloxacin. Okay, so if you see, these are 3 different classes of antimicrobials, and there is one antimicrobial to which it is resistant. So this becomes an MDR bug. What about XDR? XDR is basically something which is resistance to one agent in all classes of antibiotics except two classes of antibiotics. That is, it is to only two classes of antibiotics. Rest all antibiotic classes, at least one agent it is resistant to. Remember, other classes of antibiotics where it is resistant to at least one agent, it can be resistant to all agents or at least one agent. Even then, it is called as an XDR. So remember this term as well. And what about PDR? PDR is resistance to all antimicrobial categories, all agents and all antimicrobial categories. That is called as PDR. So in our day-to-day issues, we are seeing a lot of MDR. We are also seeing a lot of XDR, but PDR is a very, very dangerous situation. If you have PDR, you have nothing left to treat the patient. So based on your antibiogram, which you have on the patient, several times you will have questions whether this patient has got MDR, whether this patient has got XDR, or whether this patient has got PDR. What will be your antibiotic choices? Whether you want to give this antibiotic to a certain duration of time after source control, whether you want to switch antibiotics. These are various questions that you might get when you approach a case of septic shock. And remember, again, I will repeat, do not forget your source control. Source control is extremely, extremely important. In the midst of giving all antibiotics, fluids, hydrocort, all of that, you always forget source control. Remember to keep the surgeons in the loop, or if you can drain the source yourself, go for source control as soon as possible. So thank you for your patient listening. These are a few excerpts which I tried to put in within the constraints of time. As much as possible, I tried to share what questions that examiners might ask. Thanks a lot.
That's a very good presentation, sir. And definitely you have tackled a lot over a shot. Without any delay, I want to welcome Dr. Samir Samal, sir, to deal the question and answer sessions. Samir, sir, please share your PPT.
Am I audible?
Yes, sir, you're audible, sir. Your slides are visible. Please proceed, sir.
Okay. So coming to the last session today, question and answer session. So let's start. 31-year-old diabetic woman, headache, facial pain, mildly confused last 6 hours, febrile, black necrotic lesion on the hard palate, proptosis on the left eye, black fluid draining from the orbit. So this is the ABG, urine ketone positive. So likely cause directly straight from the class today.
Mucormycosis.
Very good. So it is mucormycosis. Excellent. So most common causative organism?
Zygomycetes.
Huh?
Zygomycetes.
Zygomycetes is a class. It is the
It's a
organism.
rhizopus.
Rhizopus. Very good. Okay, so rhizopus. So management?
Sir, amphobi. First is surgical control of the ear. By doing imaging, we have to see the extent of the lesion, and then going for antifungals.
It is extended to eye. Palate is invaded. Patient is obtunded, means frontal lobe. Okay, so this is clear case of rhinocerebral orbital mucormycosis. So surgical debridement definitely. Which and antifungal which one?
Yes. Sir, liposomal amphotericin B.
Very good. Dose?
5 to 10 mg per kg.
5. Very good. Excellent. 5 to 10 mg per kg. May go for higher doses, 10 mg per kg, because there is so much of invasion. And another thing in management, another important thing.
Decay management.
Very good. Decay management. Decay has to be controlled. Okay. Very good. Very good. So 45-year-old man, Australia, wet season, fever, cough and myalgia, mildly confused, muscle tenderness marked. There is hypoxemic respiratory failure, support on ventilator, tracheal aspirates, GNB. initial antibiotic therapy. So culture has been drawn, ET culture. So initial antimicrobial therapy. Anyone? So there is hypoxemic respiratory failure. So mostly the source is
Lung.
lungs. Source of infection lungs. So patient has come from community. Community acquired pneumonia. What will you give? Which antibiotic?
So beta lactam with macrolide combination.
Okay, very good. So that you have to give. And along with that, because there is myalgia and patient is from, okay, Australia is a bit difficult here. We don't know about Australia. So because there is myalgia and all, fever and myalgia, they in Australia this is very common. What is this? Burkholderia. Okay, your melioidosis, Burkholderia pseudomallei. Okay. So that is what he is trying to ask. So which therapy for Burkholderia?
Ceftazidime,
Yes, very
meropenem,
good. Ceftazidime or meropenem or
Septron.
don't tell Septran.
Sorry.
What is the drug? Septran is a company name. Don't tell company names.
What is it? Cotrimoxazole.
Cotrimoxazole. Very good. So 42-year-old man coughed for 2 weeks, fever and mild left hemiparesis. CT scan shows lesion in right frontal lobe. Biopsy is undertaken. Gram stain shows weekly gram-positive beaded branching filaments, weekly acid fast. What is the organism?
Listeria.
Yes? Please louder. The clue is acid fast.
Sir, somebody has written nocardia.
Who has written?
Sir, Dr. Kalyani Swine.
Okay, very good answer. That is a nocardia. Okay, so non-microtubercular infection, weekly acid fast, and a gram-positive beaded branching filament. Okay, so this is nocardia. And antibiotic for nocardia? Excellent answer, Kalyani.
Cotrimoxazole.
Very good answer. Excellent answer, Anjali. That is cotrimoxazole. Okay, for nocardia. So 26-year-old man, SOB, fever, confusion, shock, lobar pneumonia, gram-positive diplococci. This is your VBG. Sorry, your CBC. Occasional target cells, moderate number of Howell jolly bodies. So which organism? Gram-positive diplococci, lobar pneumonia. Which organism?
Streptococcus pneumoniae.
Pneumococci.
Gram-positive diplococci in lungs. Someone told now.
Streptococcus pneumoniae.
Pneumococcal.
Pneumococcal, Streptococcus pneumoniae. Okay, very good answer. And what do the Howell jolly bodies indicate?
Post-splenectomy status.
Excellent answer. We had already discussed it, I think, two weeks back. If you remember, Howell jolly bodies. So why is he predisposed to this illness?
Calculated organ.
Vaccination.
Just give a better answer. Vaccination is not there. Patient is not vaccinated. Maybe that is why. Post-plenectomy patient, which kind of organism they are susceptible to?
Capsulated organism.
Capsulated organism. Very good. Capsulated organism. Okay. Can you name other capsulated organisms?
Hemophilus influenzae.
Yes, very good. Any other?
Neisseria.
Meningococcal.
Neisseria, sir.
Yes, Neisseria meningitis. Very good. Salmonella, Pseudomonas. Okay.
Okay.
So what measure could have been undertaken? Vaccination. Okay. Very good. So everything is answered. Excellent. Very good. So 55-year-old hepatitis C positive patient, woman, known CLD, neck stiffness and drowsiness. CSF shows cell count high 90, 70% neutrophil, RBC 1, protein high 0.6, glucose low 1.1, blood culture shows gram positive bacilli. So what is the likely diagnosis?
Bacterial meningitis.
Yes.
Acute pyogenic meningitis.
Yeah. What is the most likely organism?
Listeria monocytogenes.
Yes. Very good. Very good. Very good. So what is the key for Listeria here?
Immunosuppression, CLD.
Elderly patient, gram positive bacilli.
Very good. Gram positive bacilli. Okay. So gram positive bacilli, it is Listeria. Treatment?
Ampicillin.
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 Very good. Ampicillin. Very good. Dose?
2 grams per hour.
2 grams
3 grams for hourly.
Yes, 3 gram. 4 hourly. No, maximum you can give 12 gram per day. Okay. So 3 gram QAD.
6
hourly.
hourly.
Yeah, 6 hourly. 3 gram 6 hourly. Maximum you can give 12 gram per day. That is the maximum dose. Okay. Very good. Very good answer. And suppose patient is sensitive to penicillin, has penicillin allergy. Then which drug we can give?
Ampicillin.
That is also penicillin. Patient has penicillin allergy. So which drug will you give?
Sir, Astronam.
No. That is meningitis. Astronam is not a good age.
Okay.
One drug for all infections.
Meropenem.
No. Listeria meropenem.
Macrolides.
Cotrimox.
Yes. Somebody told. Somebody told yes. Yes, yes, yes. Okay. So it is Cotrimoxazole. Okay.
Okay, sir.
3-year-old child diarrhea for 1 week. It is lethargic and irritable. So your electrolytes, sodium is normal, potassium on the higher side, urea is raised, creatinine is also raised, bilirubin is raised, bilirubin is high, 48, TLC normal, platelet is low, cystocytes present. Diagnosis?
Leptospira.
Hemolytic uremic syndrome.
HUS.
HUS, very good. Why leptospira, Subhadip? Why did you tell leptospira? Only because of jaundice?
It's a jaundice with.
With what is?
There is hyperkalemia and high bilirubin suggesting hemolysis with low hemoglobin and high retic.
HUS. Okay. Retic is raised. Okay. So which one causes HUS? Which organism?
Shigella.
And
Enterotoxinic E. coli.
enterotoxic or
Entero-invasive.
enteroinvasive. No.
Sir, E. coli strain O157 is most
What
common.
is that? There is hemolysis going on, no?
Enterohemorrhagic.
EHEC.
Yes, it is
EHEC.
EHEC. Yes, O157. Good, Subhadeep, good, very good. Anjali, very good. Everyone, very good, excellent. So, 27-year-old woman, New Guinea, leave it. Driving holiday, febrile with rigors, today comatose and fits, seizures. Again, urea raised, creatinine raised, bilirubin raised, LDH raised, hypoglycemia,
Malaria,
TLC,
cerebral malaria. Cerebral malaria.
Excellent answer. Very good. Which one causes cerebral malaria?
Falciparum.
Falciparum. Very good. So, which investigation?
PBS. PBS.
Peripheral blood smear. Okay.
TBC,
Please little more specific smear.
Yes, sir.
Little more specific about smear.
Thin smear to identify the species.
Yes, thick and thin smear both has to be done. Okay.
Thick and thin smear.
Yes.
The James skin.
Very good. So treatment.
IV artesunate 120 milligrams.
Dose.
120 milligrams.
So 120 given at 12 hourly apart, 2 dosages. First loading, then 2 dosages, then once daily.
Yeah. So 120 mg, 0, 12, 24, then OT. Okay. Any other drug which is given this way?
Sir, ticoplanin.
Very good. Ticoplanin is given that way. Okay. Any alternative for artesunate? Pregnant women?
Clindamycin. Clindamycin?
No.
So chloroquine.
For falciparum?
No, that's for
Oh, 5 falciparum. Yeah.
quinine and clindamycin.
Yes. Quinine. What is the side effect of quinine?
Hypoglycemia.
Very good. Very good. And?
Good. Okay, sir.
And?
QT prolongation and arrhythmia.
Arrhythmias. Very good. Very good. In which trimester can you give quinine? First, okay. So, 48-year-old man, flank pain, fever,
Sir,
rigor.
last question remaining, sir. Steroids, regarding steroids.
Very simple. Tell.
No role.
No role or they worsen the outcome. Okay.
Okay.
Negative impact. Okay.
Okay.
Steroids should be avoided in falciparum. So 48-year-old man, severe flank pain, fevers and rigors, pulse 130, blood pressure 60-20 shock, urine microscopy, very high cell count with bacteria, 10 liter of NS and AP and infusion was given, started. Patient was intubated and ventilation for deteriorating gas exchange. So possible organism?
E. coli.
E. coli.
Yes, and everything. Tell all.
Gram negative. Gram negative.
Yes, gram negative, Enterobacter C. Tell all. Tell all gram negative bacilli and tell 1 gram positive.
E. coli, Klebsiella.
Yes, E. coli, Klebsiella. Another?
Sir, Pseudomonas.
Pseudomonas. Very good. And 1 gram positive?
Streptococcus.
Yes.
Enterococcus.
Enterococcus.
The reason why we add ticoplanin in severe shock patient with UTI, although there is no suspicion of MRSA, that is enterococcus. Okay, any abdominal infection, suspecting any urinary tract infection, or suspecting in a patient in severe shock, we have to add a ticoplanin, although there is no risk of MRSA. Okay. Okay, that is the cause of adding ticoplanin in all worsening shock patients to cover enterococcus. Okay. Yeah. So, radiological investigation.
CT abdomen in hemodynamic unstable patient and CT in hemodynamically stable patient.
Very good. So don't tell only abdomen, tell abdomen always. Okay. Then CT. Okay. Then your urgent surgery when to be done?
Xanthogranulomatous pyelonephritis.
Very good. Pyelonephritis or
Abscess.
Abscess. Very good. Renal abscess or perinephritis, pyelonephritis, pyonephrosis. Very good. 48-year-old man, non-productive cough for 1 week, fever and SOB. Patient is on diclofenac, methotrexate and prednisolone for rheumatoid arthritis. X-ray shows diffuse interstitial infiltrates. SpO2 73% on 6 liters. BAL was performed. Gram-Stein and cultures are negative. Straightforward answer. Positive microorganism.
Pneumocystis.
Pneumocystis. Excellent. Diffuse interstitial infiltrates. Gram-Stein culture negative. Pneumocystis. Excellent. How to confirm?
PCP stain.
PCP stain. Very good. And newer methods. PCP stain is what? Name the stain.
Silver methamine.
Methamine silver. Okay. Very good. And newer methods.
PCR.
PCR. Very good. Very good. Excellent answer. So, treatment.
Cotrimoxazole.
Very good. Excellent answer. Anyone can tell the dose?
Trimethoprim dose of 15 milligram per kg.
Yeah, 15 to 20 milligram per
Divided
kg per day in 3 to 4 doses. Very good.
Yes, sir. Divided in 3 doses.
Yeah. Duration of treatment, how much do you expect to give?
Around 6 weeks.
No, not so long.
T.
Guess. Two weeks is sufficient. Okay. I will tell when you have to prolong the course after some questions. You tell me. So, how long is 2 weeks? Okay. So, alternative agent?
Gentamicin.
No. Anyone? It's pentamidine. Okay. So, what coexisting infection you should be looking for?
TB and HIV.
HIV. Very good. So, in this case, you have to give cotrimoxazole for 3 weeks. Okay. Okay. So, this is the duration 3 weeks. Otherwise, it is 2 weeks. Okay. Role of steroids.
Yes.
Yes, it is definitely. It has to be given.
Yeah.
Okay. Definitely effective in HIV patients, although not proven in non-HIV patients, but it is still used. Okay. Definitely steroids for PCV infection. Okay. Just tell me when you give. Have you ever prescribed IV cotrimoxazole?
Yes, sir.
how do you prescribe? What do you write in your notes? What do you tell the sister to give?
So it comes in single strength as well as double strength.
Yes.
So one ampule contains single strength contains 80 milligram of trimethoprim and 400 milligram of sulfamethoxazole.
Yes.
So
how do
we
you
usually
give
prescribe for adult if it is 15 milligram per kg for the 50 kg male, it will be
Yes.
approximately 900 milligram per day. So we
Yes.
usually prescribe IV cotrimazole double strength, 2 ampules TDS. Like
Yes.
will
Yeah,
be
but
prescribed with
say like
20
that.
milligram TDS.
It's a clear cut because they will not be able to calculate. You have to tell 10 ml or 15 ml TDS, 10 ml TDS according to the weight of the patient. Okay. Okay. Just practical, nothing regarding the practical aspect. Okay. So next question is 32-year-old woman, 48 hours of cough, fever, rigor, increasing SOB, bronchial breathing at right lung base, X-ray consolidation right lower lobe, Streptococcus pneumoniae, Benzyl penicillin started. He was intubated and ventilated. Then now patient is deteriorating. FiO2 0.9, peak pressure 30, peak 15, high inverse ratio ventilation, PaO2 is 55. So bilateral alveolar infiltrates consistent with ARDS, high grade fever, TLC is 25. So tell me why patient not improving. So this is a case of
Hospital required money.
The drug resistance.
very good drug resistance. Then
Ventilator associated pneumonia.
very good.
Hospital acquired pneumonia.
Yes.
Apnea.
Yes, very good. That are the worsening causes. Any other cause?
And multi-drug resistant.
Drug resistance is told. So in this, I'm trying to ask you, what are the causes of non-responders?
Yes, sir. Continue, sir.
Non-resolving pneumonia. Causes of non-resolving pneumonia.
Empyema.
Polymicrobial.
So there was a
Polymicrobial.
dense consolidation, polymicrobial, okay. There was a dense consolidation right lobe, that could be a empyema, okay.
Okay.
So that could be one cause. Other non-resolving pneumonia causes?
Sir, Acinetobacter baumannii.
That is hospital acquired. Take it as hospital
Yeah,
acquired.
okay. And intubated ventilation depends on the suction time, suctioning of the.
No, there are 4 or 5 causes direct. Then. Anyone?
Sir, resistance,
Misdiagnosed
misdiagnosed organism.
Everything is good.
So abscess formation.
Now I'm not asking you with regards to this case. I am asking you in general.
Abscess formation.
So
Abscess
then maybe misdiagnosed organism
Yes, in correct diagnosis. Very good. Then
and organizing cryptogenic organizing pneumonias, large abscess, empyema.
that is already discussed. Then
Mm.
now don't think about this case. In general, I am asking what are the causes of non-resolving pneumonia.
Giving non-susceptible antibiotics.
Fungal infection.
Yes, fungal infection, tubercular infection, like that. Very good.
Hyperglycemia.
No. Okay, that is one of several under a particular category. Okay, I'm telling you. Okay, so whenever somebody asks you what are the causes of non-resolving pneumonia, first is your incorrect organism. Okay, incorrect diagnosis. then inadequate antibiotic, okay, dosing and all. That is why I told you don't think about this case, because I wanted to hear inadequate dosing. Okay, you cannot give like meropenem 1 gram BD and expect a recovery, okay, like that. So inadequate antibiotic therapy. Then here is your impaired host defense or immunodeficiency, so there are chances of other infections, okay. Then your another cause is your atypical organism. Suppose this patient is suffering from
Mycoplasma.
any other, means atypical organism, okay. We have only given penicillin, we have not given any atypical coverage, so that can also cause atypical organism. Then is your tuberculosis, fungal and all, okay. So then again this is your post obstructive pneumonia. What is post obstructive pneumonia? Suppose there is any growth or mass in the lung.
Growth is
Yeah.
growth is blocking the bronchus, which is
Yeah.
causing the distal part to get atelectasis and
So
pneumonia.
not reaching there. Yeah, so that is what. Very good. Okay, post obstructive. So whenever someone asks you what are the causes of non-resolving pneumonia, so this question is trying to ask that. Okay. So next question: 32-year-old woman, low-grade fever, headache, confusion. CSF TLC is 50, lymphocyte 90%, protein is mildly elevated, glucose is normal, total, simple, very simple.
TB meningitis.
Why TB?
Glucose is not
Glucose is so less. Glucose is near normal.
Yes, sir. We can't pay.
Protein is only very mildly elevated.
Viral.
Viral meningitis.
Viral
HSV.
meningitis.
HSV meningitis.
HSV meningitis, very good. Any other cause? Last time also I had told. Whenever you are suspecting viral, there has to be another diagnosis along with that. Generally, in viral protein, we have seen it is raised most of the times, but generally it should be normal. Okay, so mildly raised protein, 90% lymphocyte, 50 cells, 10% neutrophil. What can be the cause? Another cause?
Scrub.
No. Last meningitis class also I had told neurology.
So
First.
autoimmune diseases.
No.
Listeria, sir.
No. Facilitated bacterial. Okay. Always have this in mind. Okay. Facilitated bacterial meningitis. Okay. Always have this in mind. So any other disease, non-infective, that can cause this?
Cancer.
So autoimmune meningitis.
Autoimmune meningitis, very good. And
The cancer.
Cancer, be specific.
Yes, sir. Okay.
Be specific. 90% lymphocyte.
Lymphoma. Cerebral lymphoma. Central lymphoma.
CNS lymphoma. Okay, very good. So next, what are your steps for investigations?
Lumbar puncture, sir. Then
It's done, no?
yes, sir.
ABC followed by imaging.
Imaging, very good. Imaging. What imaging?
Sir, MRI.
MRI, very good. MRI. And CSF you want to further investigate?
Sir, PCR.
PCR.
For
viral. Yes, sir.
For viral markers.
Viral. You can send autoimmune also. Can send cryptococcus also. You can send TrueNet, CBNet, whatever is available. Okay.
Yes.
Whenever the examiner is asking any question, no, means once your question answer regarding the case is over and they are asking more answers, then you don't remain in the case. Come out of the case and give general answers. We are already always stuck that in this case it is not necessary. Why should I answer? Why should I answer? That part is done. When your examiner asking you more, means you always have to go in general. Okay. Because otherwise the other diagnosis like cryptococcus will not come to your mind, because we always stay in this question only. Okay. So whenever your examiner is asking you after your given first answer, like first diagnosis needs to be completed. So once you have told viral, he's asking more, then leave this case. Come outside and tell what other pictures can show this. Okay. So those means drug for viral meningoencephalitis, suspecting it is HSV.
Sir, injection acyclovir 5 mg per kg.
Cyclovir
5 mg per kg is how much?
10 to 15 mg per kg per day dose.
10 mg per kg. Okay. So 5 mg per kg is less. 5 mg amounts to 250 mg TDS. You give 250 mg TDS to meningitis patient.
Sorry.
500, no?
Yes, sir.
500 mg TDS. Okay. Okay. So 56-year-old man, pyelonephritis, ceftriaxone 1 gram daily, obstructed right kidney, nephrostomy is done. Blood cultures show Enterobacter cloacae sensitive to ceftriaxone. Pus from renal pelvis shows GNB or microscopy. Again, cultures showing Enterobacter cloacae sensitive to ceftriaxone. So tell. Are they generally sensitive to ceftriaxone?
Intrinsically resistant.
Yes. Although your in vitro is showing sensitive, it is generally resistant to your cephalosporins. Okay. Got it?
Yes, sir.
So what drug will you give?
Penem. Penems.
Yeah, very good. Carbapenems. Okay, very good. So 28-year-old men. Okay, just tell me one. There is one organism, Klebsiella pneumoniae. Okay, 10 to the power 5 coliform unit in urine. Patient is that culture is sensitive to imipenem, resistant to all cephalosporin, all group of cephalosporin. Patient is sensitive to imipenem, resistant to meropenem. Patient is sensitive to polymyxin, resistant to colistin. Which drug will you give? Patient is in shock.
Resistant to colistin.
Yeah.
And but polymyxin B cannot be in urine, isolate because it doesn't concentrate there.
Yeah, very good. So which drug will you give?
The other one, imipenem.
Which other one? Patient is sensitive to imipenem but resistant to meropenem.
Okay, so carbapenem, resistant.
But
We
in
can
imipenem sensitive less than 0.5. MIC less than 0.5, imipenem sensitivity, meropenem resistant, polymyxin B sensitive, colistin resistant. What drug will you give? You might have seen many reports where one
Yes, sir.
group of carbapenem is sensitive, one group is resistant. So what does that indicate?
Sir, multi-drug resistant MDR.
It is MDR, but will you give imipenem to this patient?
Sir.
Will give Javisafta Astriona.
Very good. And once again, don't tell Javisafta.
ceftazidime-avibactam.
Yeah, ceftazidime-avibactam and aspirin. Okay. So if your one carbapenem is also resistant in vitro, that means the organism is producing carbapenem.
Yes,
Yeah.
yes,
So it is also sensitive to one, resistant to one. But if it is resistant to one, means it is resistant to your whole class. Yeah. Okay. Because it is resistant to meropenem means it is producing carbapenem. So you cannot give imipenem in this. You have to go for ceftazidime-avibactam and aspirin. And mostly in Delhi, I'm saying in India, every one of us, even we, if you do your biofire from your throat swab, it will come Klebsiella indium. Okay.
Yes,
In India, every one of us, most of us have a NDM producing. So you have to add astronam also. Okay.
Okay.
Okay. So 28-year-old woman presents with 3-day history of fever, cough, sore throat, earache, bilateral crackles, skin lesions suggestive of erythema multiforme, cold agglutinin plus, UPT plus. What is the diagnosis?
Pseudomonas.
Why?
Sir, cold agglutinin is positive and chest auscultation bilateral crackles in scrapes. So atypical EA and cold agglutinin chlamydia, sir.
You are good, correct about atypical but not chlamydia. Pneumonia is present, crackles.
Mycoplasma.
Mycoplasma pneumonia.
Pneumonia.
Okay. Okay. So which therapy treatment? What will you give to this patient?
The patient is pregnant, so doxycycline cannot be given. So, sir, macrolides. Macrolides.
Yes, macrolides. Okay, very good. Actual answer is tetracycline and doxycycline, but since your uterine pregnancy test is positive, we cannot give tetracycline. We have to give macrolides. Very good. So, 68-year-old man cut his foot on shell, seaside. Mild cellulitis, ulceration, then immediately, very rapidly to fulminant necrotizing cellulitis. Shock. Blood culture shows gram-negative bacilli. Seaside, single answer. Likely pathogen?
Pseudomonas.
Melioidosis.
No, seaside, only single
Sir,
organism.
Vibrio vulnificens or Vibrio?
Vibrio
water.
Seaside, single answer. Vibrio vulnificens. Okay, very good.
Rapid progression, yes, sir.
Yes. So, what antibiotic?
Empiric, sir, we'll give empiric.
What? Tetracyclines, okay. All Vibrio gives tetracyclines. Okay.
Yes, sir.
Other are that can be given as your fluoroquinolones can be also given. So 32-year last question today, then you can leave. So 32-year-old male, 1 week of confusion, seizure, 1 day, known case of IV drug abuse, lost weight over 3 months, lymphadenopathy plus, multiple cerebral lesions, bilateral, basal ganglia involvement plus, hypodense with ring enhancement after IV contrast. Again,
Cerebral TB.
Huh?
Tuberculosis, sir.
No, there is a region given, no involvement.
Toxoplasma.
Yes, toxoplasma gondii. IV drug abuse, mostly immunocompromised. Basal ganglia involvement, multiple bilateral separation with involvement of basal ganglia, that is toxoplasma gondii. Very good answer. Differential. Differential can be your TB. Differential can be lymphoma, CNS lymphoma. Multiple lesions, bilateral can be CNS lymphoma. Differential can be TB, although basal ganglia goes for toxoplasma. Okay.
Neurocystic sarcosis.
Neurocystic sarcosis, yes, sir.
Sarcosis, very good. Then recommended therapy.
Pentambrin.
Yes. Which drug? Very atypical drug.
Pyrimethamine.
Yes, very good, very good. Pyrimethamine. Okay. Now, what is the side effect? And for that, what you have to give?
Folic.
Bone marrow depression.
Sir,
Pyrimethamine.
pyrimethamine is combined with folic acid derivatives of folinic
Yes.
and folic acid.
Yes. Why? Folinic
Due to
acid. Why?
bone marrow suppression and
Yes. For
it's
myeloid. Yeah. Very good.
anti-metabolite drug. So
Yeah. Very good. So as you are suspecting immunosuppression, patient can be HIV. We will also start antiretroviral in this patient. And alternatives to pyrimethamine, anyone?
I think clindamycin, azithromycin.
Yeah, very good. Clindamycin can be given. Okay.
Okay.
Okay. So that's all for today. Thank you very much. Any doubts? Write in the group. Again, any recommendations or any topics specific you want, is write in the group. Okay. So I hope all of you enjoyed today. You learned.
Yeah.
I hope these classes that we are taking, whatever you have joined, the reason for that you have joined, that is being fulfilled, how much even possible. Okay, so thank you. Goodbye for today. Good night.
Yes, sir.
Thank you.
Bye.
thank you, sir. Thank you.